Uh, Namaskar and good evening, everyone. I welcome you
It's
all
6
for
o'clock.
today's webinar on Third Blessed Clinical Oncology Symposium, recent clinical updates on various topics of cancers: lung cancer, breast cancer, GI cancer, GU cancers, head and neck cancers, and hematologic malignancies. And with immense pleasure, I invite today Dr. Tejinder Singh, who is Senior Divisional Medical Officer, Northern Railway, Central Hospital, Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thanks. Good evening, dear friends and colleagues. Today, it gives me immense pleasure to welcome you all for the third Best Clinical Oncology Symposium, which is being done under the aegis of SOMEX Research and Health Organization. The scientific committee has worked tirelessly to ensure we have good scientific deliberations from national experts. My sincere thanks to Dr. Naresh Somani, Dr. T.P. Shahu, Dr. Manish Kumar for the great efforts they have done. Truly appreciate the timely support from the pharma colleagues to make it happen. So without much ado, let's have a meaningful clinical discussion and hope you all will enjoy this academic feast. Now, to we start over, the first expert will be Dr. Sandeep Batra. He is the Director of Medical Oncology in Max Super Specialty, New Delhi. He will be speaking on clinical updates from ASCO GI 2022. What's new in this? So I welcome Dr. Sandeep Batra. So kindly deliver your talk.
Thank you, Tejinder sir. Thank you, Dr. Naresh Somani, and thank you, Dr. J.V. Sharma and the organizing team for giving me this opportunity. So I have been asked to dwell upon the meaningful updates in GI in ASCO 2022 this year. And we have selected almost about 7 abstracts in their descending order of their significance as well as probably controversy. I think they are going to make a difference in the outcome of our practice. So to start with, the first and foremost is the abstract that is chosen from none other than the abstract, which has made the headlines in the newspaper of the world, as well as all of you must have got the messages from all your pre-existing or new patients about the immunotherapy in the cancers. So this was the abstract, which I have not been lucky enough to go through in length as a paper, but as far as abstract is concerned, the organizers were considerate enough to get it organized for us. So this was PD-1 blockade as curative intent treatment in mismatch repair deficient locally advanced rectal cancer. So mismatch repair. So as on today, rectal cancer, especially the middle and the lower third, the standard of treatment is chemoradiation, chemotherapy, and surgery. And obviously, because the sphincter cannot be preserved, most of these patients end up losing their rectum. So this particular trial was addressing the issue of preserving the rectum, the organ preservation for as long as possible and maybe for life. And for that, they carefully selected patients who were MMRD deficient, that is MSII tumors. We already know MSII tumors have a predilection to respond to immunotherapy, and about 20 to 30% response rate, of which there are a good number of complete responders we have already seen in our metastatic setting. So this was, as usual, a drug which appears in the metastatic setting, then moves on to the adjuvant setting, and then moves on to the neoadjuvant setting. Probably in rectal cancer, we are seeing it has jumped directly from the metastatic setting to the neoadjuvant setting for the unmet need of organ preservation. So just the statistic, out of the almost 750,000 patients of rectal cancer diagnosed in a year annually, about 2 to 10% based on the patient selection and the clinical history, 2 to 10% are found MSI high or MMRD deficient tumors. And these are the tumors which respond to immunotherapy well in the metastatic setting with a documented complete response rate of 10%. Now, there was a hypothesis generated that in mismatch repair, So the hypothesis was generated that in mismatch repair deficient rectal cancer, PD-1 blockade may be either able to replace chemotherapy, replace both chemo and radiation therapy, and last but not the least, replace both chemo, radiation, as well as the surgery. That is a total neoadjuvant treatment sort of thing, leading to a complete CR, practically unheard of till date in this particular disease. So the drug was dostarlimab, which was used 500 milligram IV every 3 weekly over 6 months with frequent mandatory rather radiological and endoscopic evaluation. And if there was a clinical complete response, patient was kept on non-operative follow-up every 4 months. And all those patients in which there was a residual disease after the completion of 6 months of dostarlimab, mandatory chemoradiation was done, and then they were followed up. If there was a clinical complete response, which included frequent MRIs, the colonoscopies, and the biopsy of any suspicious area, only when they all were negative, they were labeled as a clinical complete response. At the slighted evidence of the disease, they all progressed with the doing this surgery. So this was the schema of these patients. Patient population stage 2 and 3 mismatch repair deficient rectal cancers. That means patients T1 to T4 and node positive, all of them were included. Metastatic were not. Target enrollment was 30 subjects because it was a proof of concept sort of trial. And study design was Simon's two-stage mini-max design. Primary objective was overall response rate of PD-1 blockade with or without chemoradiation. And a second primary objective was pathological complete or clinical complete response at 12 months after PD-1 blockade with or without chemoradiation. Secondary objectives being safety and tolerability. So what were the response criteria for the overall response? Rectal MRI, endoscopic exam graded as stable disease, partial response, near complete response, and complete response. They were basically done on the basis of the rectal MRI at the colonoscopic examination. Clinical complete response was endoscopic examination, visual disappearance of the rectal primary and normal digital rectal examination, which was followed by rectal MRI, which did not show any lymph node, which was more than 5 millimeter. And there was an lack of signal at in T2W1 weighted images. So these were the statistical consideration. The null hypothesis was that an overall response rate less than 25% based on response to chemotherapy in MRD deficient tumor of 7%. And reduction of this null hypothesis required a response in 11 or more patients. The target population was approximately 30. So they were almost equitable distribution of the rectal cancer as we see in the clinical practice, but slightly more females in this demography as compared to what we see in the clinical practice. Otherwise, age-wise, race, ethnicity, as per their local propensity, tumor staging-wise, T1 to T3, 4, and node positive versus node negative. Only one node negative patient was there. And as far as MSI status was concerned, 10 were MSI high and 7 were MSI low. There was no BRAF wild mutation, and tumor mutational burden average was 67 with a range of 36 to 106, which is again a surrogate of a MSI high status. Higher the tumor mutational burden, higher are the chances of response to the immunotherapy. So please note, advanced cancers, T3, T4 stage and node positive stage, they were the most of the patients, not a very early stage patient. Now, individual response to PD-1 blockade was seen. So you can see from left to right. At the baseline, the clinical tumor on endoscopy, MRI, and PET-CT. Then at 6 weeks, then at 3 months, 6 months, you see from left to right. From the left, a very shabby and ugly looking tumor. From the right to the extreme right follow-up at 22 months. So it is a very clean looking intestinal mucosa. And the same is being evident in the MR and the PET-CT scan. So clinical as well as the radiological response was seen. Again, now this is the complete table which has been made available to us as an abstract. So if you see overall response, 14 patients, clinical complete response was seen in all the patients. So I have not yet seen any of the trial reporting such an impressive result. Extremes of ages starting from somewhere around 27 to as high as 78 with the tumor stage T4, T3 as well as node positive disease. Over a follow-up of approximately 24 months, with the least follow-up of about 1 to 2 months, with a digital rectal exam showing complete response, endoscopic best response, complete response, rectal MRI, complete response, overall response, complete clinical response. So this is something which are definitely going to make sensation, and that has already made a sensation worldwide. Now, if you see this graph, so it is a depiction of all the patients, and the line which is covering all the yellow dots is line at the completion of 6 months of dostarlimab treatment. So you can see 3 patients, 3, 1, 2, 3, 4, 5, 6, 7. 7 are still to complete that clinical complete response evaluation at the completion of 6 months. And there is an ongoing response with a median follow-up of 6 to 8 months, with a duration of 0.7 to 23.8 months. So key observations: 100% complete response, no grade 3 or 4 adverse event, no patient required chemotherapy, radiation, or surgery, no disease recurrence as far as the follow-up period was closed. So longer follow-up, obviously, the investigator also feel is required, but because this is only a response, this is not sacrosanct for the overall survival or precursor of the overall survival. So to conclude, the investigators said that this data provides framework for immunoablative therapies and highlights biomarker-driven therapy in early stage cancer. And since 3 to 4% of all cancers are MSI high, there is a potential of this trial and this drug data to be contemplated into the real practice, especially in those countries where we don't have modern chemotherapy, radiation, and surgery facilities. So this is already published into the NAGM. So this was the most important abstract and most talked about abstract in the GI cancers in the ESCO this year. The second abstract is for modified folfixary plus panitumab, that is M-folfixary panitumab versus M-folfoxib panitumab. So most of the time, younger patients, unresectable metastatic disease, which has RAS-RAF mild type, we tend to give triplets along with the anti-EGFR therapy, or for that matter, anti-VEGF based on the leftness or rightness of the tumors for the response rate. But this trial tried to address the issue whether intensification of the treatment with the triplet in those patients who are unresectable, when you are adding this anti-EGFR therapy, is it really worth? So whether we should go for a triplet with the anti-EGFR, which has been proven in the phase 2 and the other trials by other investigators, or we should restrict ourselves to a doublet combination, saving on the cost of the treatment as well as the toxicity of the treatment with the panitumumab. So again, the background was doublet versus triplet with the anti-EGFR therapy. Since some trials in the past have shown promising results with the triplet with the anti-EGFR therapy, but not compared that triplet with the doublet as far as anti-EGFR therapy combination is concerned, except for a phase 2 Wolfe trial. So this trial addressed that issue head on by using a doublet versus triplet with the same anti-EGFR therapy in the both the things. So objective was to verify the added value of intensified first-line chemotherapy when this is combined with a targeted agent, panitumumab, in a molecularly selected RAS and RAF wild type population of MRA, metastatic colorectal cancer. So this was the schema. First line patients, treatment 9, M-folfox plus PAN, M-folfox plus panitumab until maximum 12 cycles, or M-folfoxib per panitumab until 12 cycles, followed by the maintenance 5-FU leucovorin with panitumab in both the lines till the progression. There was a progression, till progression disease was there. 57 centers and a data of 4 years has been captured. This is for triplet trial. Now, over the years, we have decreased the doses of some of the drugs, especially irinotecan, in most of the protocols at 5-FU. And the final that has come up in this trial was irinotecan 150 milligram per meter square, oxali 85, and 5-FU 25, 400 milligram per meter square, and panitumab 6 milligram per kg. Primary endpoint, objective response rate, because you are using a doublet or a triplet for the responses. Expected overall response rate in arm A, that is triplets plus panitumab, was 60%. And the hypothesis was to detect a more than 15% increase in overall response in arm B, that is folfixary plus panitumab versus the folfox with panitumab. 432 patients to be randomized. What to be randomized? Secondary endpoints were early tumor shrinkage, deepness of response, progression-free survival, R0 resection rate, overall survival, which is yet not mature, and translation analysis, which is still ongoing. Key eligibility criteria, again, metastatic patients, either first line, or if they have received adjuvant treatment in the early stage 1, 2, 3 setting, then they should not be having a OXA containing regimen. And if it was 5-FU based monotherapy, more than 6 months had to be lapsed from the endo, adjuvant, and first relapse. Again, needless to say, bone marrow, liver, and functions were to be adequate. So epidemiology by demographic wise, intention to treat population was well matched in both the arms. So this was the response. Arm A, folfox plus panitumab. Arm B, M-folfoxib plus panitumab. Complete response 7%, partial response 69, 66. Response rates almost same. P-value 0.526. Stable disease, again same. Progressive disease, almost same. Not assessed, 2%. R0 section rate, again 29 and 25%. P-value not significant. So you can make out from this table whether it was the control arm or the investigational arm, there was no significant difference between the response rate, whether it was complete, partial, stable disease, progressive disease, or resections. So that gives me the belief that these patients, most of the metastatic colorectal patients, do not require a triplet unless until you need unless until you are not contemplating a panitumumab or an anti-EGFR therapy to be combined. So a doublet with the anti-EGFR therapy, panitumumab in this trial, fares well as compared to a triplet with the panitumumab. So again, deepness of response, tumor shrinkage was the same in both the arms. The follow the curves, they are almost intertwining curves. No significant difference between the median progression-free survival, 12.3 versus 12.7 months, with p-value 0.277, which makes it an insignificant thing. Again, subgroup analysis across the board, all type of demographic criteria, the response were almost similar. Progression-free survival favored, though HR ratio was in favor of the doublet with the panitumumab, but as far as, since it is crossing the midline, all the lines, so it is taken as a thing that both the things are equal. So that means you can easily assume that the doublet with the panitumumab is equal, if not good, to the triplet versus panitumumab. The toxicity obviously were more in the triplet with the panitumumab. To summarize, this trial said the primary endpoint is not met. That is, the intensification of the upfront chemotherapy with M-folfoxirine is not associated with improved overall response rate as compared with M-folfox6 when both the regimens are combined with panitumumab. So tomorrow, if you are going to do a clinical practice, then doing a M-folfox with the panitumumab is as good as M-folfoxirine panitumumab minus the cost and the toxicity associated with the triplets. And mind you, folfoxirine is a toxic combination, and obviously the side effects, including mortality rate, is higher with the triplet combination. They concluded that M-folfoxirine plus panitumumab should not be recommended as upfront therapy for RAS-TRAF wild-type tumors. And obviously, I could not go into the detail of that. Obviously, we also have changed our practice with the left side tumors being given anti-EGFR therapy. So this group was a subgroup which benefited more irrespective of folfox or folfox3 backbone with the panitumumab combination. So this is again published in the ESMO. Third abstract, I will be a little bit faster due to the time constraints. So third abstract, again, we have already seen that intermittent versus continuous therapy, especially in the colorectal, and if we draw analogy from other tumors, prostate cancer also, they improve the quality of life, they decrease the cost of treatment, and they give either equal or better outcome with the continuous treatment. So intermittent treatment versus continuous treatment of metastatic colorectal patients, first line with the FOLFIRI and panitumumab, the improved study. So background, again, I have told you that it is basically to find out whether by decreasing the exposure to the treatment, decreasing the duration of treatment, giving the drug holidays, either gives a similar result or better results in our metastatic colorectal patients. So this was the schema. Arm A was FOLFIRI plus panitumumab, which was continued till progression, followed by second line treatment. In contrast, the investigational arm was arm B, FOLFIRI plus panitumumab, up to 8 cycle, followed by treatment-free interval. And then on progression, they were re-exposed to the FOLFIRI plus panitumumab, and they were continued for 8 cycle, followed by treatment-free interval. And on progression, they were put on the second line of chemotherapy. And tumor assessment was always done every 2 months in both arms. Primary endpoint was progression-free survival of treatment at 1 year. EFS at 1 year in the continuous versus intermittent arm. And the secondary endpoint, obviously, safety profile, response rate, deepness of response, overall survival, quality of life, and ctDNA, as is there in the most of the studies. Eligibility criteria, again, metastatic colorectal patients, and if adjuvant chemotherapy were received, more than 6 months should have elapsed, adequate liver and other functions. Randomization was 1:1 randomization in both the arm. So in the continuous arm, only 7 patients are remaining on treatment as of the date of publication of data. In contrast, in the intermittent arm, 25 patients were still on treatment as compared to 7 on treatment in the continuous arm. So intermittent, more patients were on treatment when the data was analyzed in this trial. Obviously, demographics matched in both the arms. Ongoing treatment, again, 7 versus 25 have already been highlighted. and discontinuation rate was higher in the continuous arm, 62, that is 90% versus 63%, that is 43 patients, because of disease progression, intolerance, grade 3-4 toxicities. It seems to be. Am I audible? Am I audible?
Yes. Yes, yes. You are audible, sir. There is
Please
some
tell me
glitches.
if there is some issue with that net, please let me know. So I will proceed. Just a minute. Just a minute. Responses, but that is at the cost of the toxicity. But let's see whether the ultimate outcome was the same or not. Response wise, almost similar except for the complete response, which was slightly higher in the continuous arm. Disease control rate was almost similar, 94 versus 90%. Progressive disease rate at 4 months was almost similar, 15%, and R0 resection rate slightly higher with the numerically in the continuous arm. And these were the curves. So the blue one is the intermittent panitumumab, and the grayish one is the panitumumab continuous. And if you see, median progression-free survival was higher, 17.1 months, as compared to the continuous arm, which was 13.2 months. Again, right-sided versus left-sided. So the difference was seen more on the left-sided tumor. There is a wider separation of the clumps, but there's significant. There is a curve difference was also there, with a PFS difference of almost about 3 months in the intermittent versus continuous arm. So continuous arm on the right-sided was slightly better. On the left side, unabatedly, the intermittent arm was better than the continuous arm. Toxicities obviously with the continuous was higher. So they concluded that primary endpoint has been met with 34 patients alive without progressive disease and 1 year in the intermittent arm, with a median progression-free survival of 17.1 months. And intermittent strategy works well, particularly more promising in the left-sided, with a median PFS of 20.2 months. Since the patient population of left-sided colorectal tumor was matched in both the things, so I think this intermittent strategy worked also better for the left-sided tumors, because panitumumab was also there in the continuous arm. So lower skin-related toxicity, however, we don't have the maturity of the OS data. So the results in future time, and also with the COVID-19 pandemic that we have just faced, in which the patients were difficult for the patients to come to the hospital because of the travel logistics, probably an intermittent strategy is going to work better than the wild type continuous strategy. Coming to the abstract pool, I will be, so I had sequenced them based on their clinical significance to us. So as we are moving down, so clinical significance, though everything is significant, for practice, because of the less number of patients, the significant decreases. So this abstract, this trial worked about randomized study of temozolomide and capecitabine in patients with advanced penetrating neuroendocrine tumors, final analysis of efficacy and association with MGMT. MGMT we do in the CNS tumor because we are giving temozolomide. So this trial, which addressed one issue which has not been addressed in the past, whether using temozolomide in neuroendocrine tumors which has MGMT deficient, is it give a better outcome for these tumors? So, so these is the background. These are the combination: temozolomide, thalidomide, tem-based other promos, bevacizumab, capecitabine, of which the most popular is the temozolomide capecitabine, which we used in the neuroendocrine tumor patient, especially grade 2 or failed grade 1, and sometimes in grade 3 as well. Now, this study's design had arm A with temozolomide only, and arm B capecitabine was temozolomide. I don't know whether the scientific committee and ethics committee, how did it approve? Our ethics committee will not approve such a trial in which the standard of care is capecitabine and temozolomide, and you are removing one of the drug from the standard of care. Anyhow, since they were passed, so there must be some logic behind that. Primary endpoint was progression-free survival. Secondary endpoint was response rate, overall survival, toxicity, and other correlative endpoints. And one of them was correlation with the MGMT by the IHC as well as MGMT by promoter methylation. So the demographics, histologically matched, grade 1, 19 versus 31 patients, grade 2, 31 versus 30 patients. Grade 3 usually do not use this combination in most of the patient times. Metastatic wise same, prior treatment wise almost similar percentage. So if you see the curves, separated a little bit in between and finally they concluded into one another. So that means single agent TAM versus CAPE TAM, the outcome is going to be the same. But if we see the median number of months, single agent temozolomide 14.4 months versus capecitabine temozolomide 22.7 months with a p-value of 0.02. That means the combination CAPE TAM worked better than temozolomide alone. And that's why I was saying that probably our ethics committee would not have approved such type of trial. And trend towards improved overall survival did not lead to statistical significance in the final analysis. Median months 43.8 versus 58.7 months, p-value 0.42. Objective response rate comparable 22 versus 27 patients in both the arms. Adverse event obviously were higher in the K plus TAM arm. We already see it in the clinical practice. When they correlated MGMT deficiency, it predicts response in GMEM, but it didn't. This trial was not designed to test MGMT as a predictive biomarker. They could not conclusively see whether MGMT mutation is to be done in all NAT patients to find out whether temozolomide is going to work or not. However, since it was part of their objective as primary and secondary objectives, so they saw that MGMT mutated tumors has a better outcome as compared to the non-MGMT mutated tumors. So MGMT promoter methylation positive had a better response rate as compared to MGMT non-methylated tumors. So there was some association with PFS and OS in MGMT deficient tumors. So they concluded that there is a significant improvement in PFS with CAPE and TAM as compared to TAM alone. There is a clinically meaningful trend towards improved overall survival, though it did not reach statistical significance. Response rate is high in both arms, and combination should be included as a standard treatment option. So we cannot remove one of the drugs. As far as MGMT is concerned, so they observed that MGMT deficiency was associated with the better PFS and OS. This gives a strong biological rationale that MGMT may be productive as it in GBM, but further confirmatory testing is needed. And pending that, routine MGMT testing is not recommended in all the patients. Coming to abstract 5, I think there are still about 5-7 minutes remaining. Organizers, please let me know when I am due for my completion of the time. So, how much time left?
Almost time is about to complete.
Okay, so I will briefly
conclude in 2 to 3 minutes.
Yeah, so concluding in 2 to 3 minutes. So the next abstract was trastuzumab deruxtecan in patients with HER2 expresses unresectable recurrent biliary tract cancers. Phase 2 trial gives a proof of concept. So the need basically because we don't have in the biliary tract cancers anything significant which has come up over last 5 to 10 years, except for IDHR, IDH1 and FGFR mutations. But the drugs are either not clinically available or they are too costly to be used in the clinical practice. So since HER2 expression is there in the significant chunk of the biliary tract cancers, so trastuzumab deruxtecan was planned to be used to find out whether this is going to work or not. 32 registered patients, 24 HER2 positive and 8 HER2 low expression. So 32 patients, all of them given the same drug. And if you see the response, both the HER2 positive and the negative had a response. Obviously, HER2 positive showed a better response as compared to HER2 negative patients that we see in the graph which is in front of us. Overall survival was also more in the HER2 positive. Side effects profile was expected. Interstitial lung disease or more in this combination, we have already seen that. So they concluded that there is a promising activity of these drugs, and this drug is also active in the HER2 low expressing tumors. Interstitial lung disease requires careful monitoring. Again, so I would say this dynamic travel gives credence to our thought that in the stage 2 colon cancer, can the treatment be decided by the circulating tumor cells? Because many times we find that the patients do come to us with the test of circulating tumor cells and we are clueless whether to advise treatment or not. This trial answered that question, and coming to the conclusion of this trial, though it may not translate into clinical practice, it concluded that in stage 2 colon cancers, circulating tumor DNA guided approach compared to standard of care substantially reduce the proportion receiving adjuvant chemotherapy. So the patients with the circulating tumor DNA after surgery may derive recurrence-free survival benefit, but mind you, the data is short, only 1 year thorough follow-up, so we cannot use that into our clinical practice. Last but not the least, I will finish my talk here because this um, abstract, I was not able to find out the clinical significance of this particular thing. And though they said it is a breakthrough, but I do not agree with this particular abstract. I need to study more data about that. With this, I will thank for all of you for patient listening and the organizers for giving me this opportunity. Thank you, sir. Back to the organizers. Like pembrolizumab. So I would say, sir, we have used pembrolizumab, durvalumab, nivolumab, all the maps till date. In the metastatic setting, none of them has given a 100% response rate. So I would say there is something different in this drug. I would still say it is dose star, matlab dose star limab, dose star, not 5-star drug, because we don't know the long-term outcomes. But obviously, this drug looks to have more potential as compared to the current ICI we have, but that's just my opinion, which still is not based on any scientific support. It is just a mere observation.
So, any clue at what time this can be available in India? It is still not available. No? It is available only in some countries. No?
I think it is only in the trial available in the US. I
Only
would
in this
say
trial.
minimum 3 to 5 years waiting before this drug really sees Indian shores.
Definitely. Okay. It is now long waiting for that. So thanks, Dr. Sandeep.
Thank you, sir.
Now the next session will be taken by uh, the renowned oncologist, Dr. Vikas Goswami, who is the senior consultant in charge of the medical oncology of Max Hospital, Ghaziabad. He will be speaking on immune check inhibitors in gastric and esophageal cancers. So I invite Dr. Vikas Goswami to kindly proceed.
Thank you, Dr. Tajender. Am I audible and visible?
Yes, you are audible, sir. Please continue.
So, Dr. Tajender, I am on my phone. Unfortunately, apologies for that. My laptop was not working. So
You
I'll
are very much.
okay. So I'll start sharing my screen. This is not allowing me. Can the technical team allow me to share my screen, please?
Technical persons kindly see that it.
Okay. Now it is allowing. Dr. Tajender, am I audible?
Yes, sir. Please continue.
Okay.
Screen is still not shared here.
for the delay. So can you go to the next slide, please? So I'll be talking about the role of immunotherapy in frontline gastroesophageal adenocarcinoma. And this slide basically shows the anatomy, how do we differentiate esophageal, GE junction and gastric cancers. And for our presentation, we'll be talking about adenocarcinomas of esophagus, GE junction and stomach. Next slide. So we know the disease burden. We know that the gastric cancer is one of the leading causes, and it's the 6th leading cause of cancer-related deaths. Next slide. And the risk factors are diet, alcohol, tobacco, obesity, H. pylori, and sometimes GERD. Next slide, please. Next slide. So this is basically the AJCC 8th prognostic staging groups, and we all know that, and we'll be talking about the locally advanced and the metastatic settings. Next slide. So again, we know the disease burden of gastric cancers amongst the 3, and the most common are the loco-regional. 50% of them are in that stage, followed by distant metastasis, followed by localized disease. Next slide. So the treatment of metastatic gastric cancers by and large is guideline driven, and 2 drugs versus 3 drugs is usually the regime. Usually we give 3 drugs, but it becomes toxic, and most commonly we end up giving 2 drug cytotoxic regimes for patients in our practice. And if the patient is poor performance status, ECOG performance status more than 3, usually we end up giving just best supportive care. Next slide. Next slide. So biomarkers, as of now, till about recent time, gastric cancers and GE junction tumors were biomarker agnostic, but now we have some biomarkers, and most commonly at baseline we do 3 biomarkers. One is PD-L1, one is HER2/neu, and MSI. For MSI high, we straight away go for immune oncology drugs. For HER2/neu, we incorporate trastuzumab. For PD-L1, we are not sure how much credence do we give to this marker, because we are not sure whether it is linearly driving the predictive responses of immune oncology or not. Next slide. So in PD-L1 assays, we know the CPS and TPS scoring. For definition's sake, CPS includes PD-L1 staining of tumor cells, lymphocytes, macrophages, all divided by total viable tumors, while for tumor PD-L1 status, we only stain the PD-L1 status of the tumor cells. Next slide. Next slide. So we know Opdita, which is nivolumab, it's a blocker of PD-1 receptor, and it basically interjects between PD-L1 and PD-1 interaction, and thereby jacking up our immunity. Next slide. So we'll be talking about the Checkmate 649 trial, which basically saw the responses of nivolumab in first-line setting for gastric, GE junction, and esophageal adenocarcinomas. Next slide. So Checkmate 649 is a phase 3 study which randomized Opdita plus Folfox or Capox versus Folfox plus Capox alone. The eligibility was previously untreated advanced cancers, ECOG performance status 0 to 1, and no known HER2/neu positive status. And they were further analyzed according to PD-L1 expression more than 1 versus less than 1, and region specific Asia versus Europe versus US, and Folfox or Capox. Opdita was given in 2 doses, either a 2-weekly schedule of 240 mg or 3-weekly schedule of 360 mg versus Capox, Folfox alone, and the primary endpoint was overall survival or progression-free survival, and secondary endpoints were again the quality of life indicators and overall survival or PFS according to CPS scoring. Next slide. All the standard statistical analysis rules were followed. Next slide. Both the subgroups, all the subgroups were adequately matched in terms of age, sex, race, Asian, non-Asian, performance status, tumor size, and PDL1 status. All the arms were well balanced. Next slide. Next slide. So, Opdita versus plus Folfox or Kpox demonstrated overall survival benefit irrespective of the PDL1 CPS status. In both the arms, we can see left side shows all patients where the hazard ratio is 0.79, and this is significant with 2-year overall survival rates 28 versus 19%. The arms start separating gradually, but nevertheless there is a significant difference in the two arms. And if we talk about CPS more than 5, the separation starts earlier, and the numbers are 31 versus 19% with hazard ratio of 0.70. Next slide. Again, PFS benefit is also favoring the Opdita arm, and similar kind of PFS benefit with hazard ratio of 0.79 and 0.70 with CPS more than 5 showing a better result. Next slide. In terms of response rates also, overall response rate remained higher, and not only response rates, the duration of response for nivolumab arm was superior both in all patients and CPS more than 5. So whether it is overall response rate or PFS or overall survival, all the 3 arms showed benefit of Opdita. Next slide. Longer median overall survival and higher overall response rates were seen, of course, in not only other patients, but irrespective of MSI. So microsatellite stable on the right side or microsatellite high. In microsatellite high, we obviously expect, but this slide is there to drive home the point that even in microsatellite stable patients, the immune oncology arm was superior to Folfox alone arm. Next slide. In terms of the other subgroups, consistent overall improvement, if we can see in the forest plot, all the hazard ratios, whether it is race, sex, age, region, very importantly, Asia versus US, and tumor location or ECOG performance status are favoring the IO plus Folfox or Kpox arm. Next slide. These are the other subgroups where we can see that they are all, mind you, pre-specified subgroups. None of them are unplanned analysis. They are pre-specified subgroups where the benefit is seen in the immune oncology arm, signifying a benefit of adding Folfox. One thing which caught my attention was that the signet ring cell carcinoma, which are having bad prognosis, there the confidence interval is crossing the unity. So probably where we need a higher support of immune oncology, there the diamond is very much close to the unity. However, like I said, this is a subgroup analysis, and we can't just conclude that it was not favoring this group, because overall it was very much in favor of immune oncology drugs. Next slide. So sometimes we analyze what about CPS score less than 1 and less than 5. So here also the hazard ratio is favoring the combination arm. So for CPS less than 1, the hazard ratio is 0.85, though the confidence interval is crossing 1 in both the subgroups, whether it is less than 1 or less than 5. And in CPS less than 5, the hazard ratio is 0.94. Next slide. So Opdita plus Folfox or Kpox demonstrated higher overall response rates and longer duration of response across the CPS cutoffs. So basically they're trying to say that what about CPS more than 1 or CPS more than 5? In both the cases, the response rates and the duration of response was favoring the immune oncology arm. Next slide. Again, if we talk about the follow-ups and discontinuation of treatment, the immune-oncology arm is by and large quite okay in terms of whether it is discontinuation or duration of follow-up. So 42% of all patients randomized to Opdita plus Folfox or Kpox received subsequent treatments, thereby showing that not a very high degree of discontinuation was there. Next slide. Predominant subsequent treatments across all arms. Of course, it's a stage 4 disease, so most of the patients, both the arms, were similar in terms of receiving the chemotherapy subgroup. So thereby suggesting that since we are adding a new drug, it's not that the discontinuation is more or patients are not able to take subsequent therapies. Next slide. So moving on to the adverse effects, we know we have used immuno-oncology drugs in combination, and we know the side effects, and we know by and large they are quite manageable, and we don't find too much difference in terms of grade 3, grade 4 or serious adverse effects when we are combining the immuno-oncology drugs. Next slide. The most common side effects which we find when we are adding immuno-oncology drugs are endocrinal, like thyroid abnormalities, subsequently followed by GI, hepatic, pulmonary, renal, or skin reactions. Majority of difference, if at all we find immunologic side effects, are grade 1 or 2, and grade 3 or 4 occurred in less than 5% of cases. And the incidence of events in patients with PDL1 more than 5 was consistent with all treated patients across all arms. Next slide. Next few slides are basically trying to show that there is not much difference between the quality of life of patients when we assess them by different quality of life parameters. When we are adding a new drug, that means when we are adding Opdita, the patients are very well able to maintain the quality of life. So here we are checking according to FACT, GA, GP5. Next slide. And here also, whether it is the GACS or EQ5D or EQVAS scores, by and large, the quality of life is maintained. Next slide. Next slide. So not only the quality of life, the another parameter which they used was symptom deterioration irrespective of PDL1 status. So whether it is CPS more than 5 or all randomized patients, most of them favored quality of life and symptom improvements and other performance status qualities were maintained in the immuno-oncology drugs. Next slide. Next slide, please. Next slide. So again, this is a chart formation that across all quality of life in, parameters, when we add Opdita, whether to Folfox or to Kpox, by and large, there is not much difference. Next slide. Next slide. So in India, we have approval of Opdita for all gastric cancers, G-junction tumors, esophageal adenocarcinomas in frontline setting, irrespective of the PDL1 status. Next slide. And the dosing, the interesting dosing, apart from 240 mg for Opdita, we have 360 mg for Kpox, because that is a 3-weekly schedule. So roughly 120 mg per week kind of a formula can be used. So here they had two options, 2 weekly or 3 weekly. Next slide. So to summarize, Opdita is the first PDL1 inhibitor to demonstrate superior OS and PFS in combination with Folfox or Kpox. with overall survival benefit more than 28% of all randomized patients were alive at 2 years, and higher response rates in patients who had higher PD-L1 status, and safety issue was not a concern, and quality of life was very well maintained. Next slide. And with that, I conclude. Thank you.
Thank
cells, it negates that. So bevacizumab probably facilitates at certain level, at the level of endothelium or at the level of T cells, which increases the ability of atezolizumab to activate the immune cell and probably prime them better. So we know that in various case reports, spontaneous regressions of tumor has been seen and observed in HCC, which probably led the researchers to believe that, okay, there is some immune mechanism that is related to the pathogenesis of HCC, like we had already seen in renal cell carcinoma as well. Tumor infiltrating T cells have been found in more than 50% of the HCC patients, and HCC may evade immune checkpoint inhibitors by expressing various markers like PD1, PDL1, CTLA4, TIM3, and LAG3. So next slide, please. Now, atezolizumab, it promotes the T cell activation by allowing the B7-1 co-stimulation. Bevacizumab, it promotes the dendritic cell maturation, and it also normalizes tumor vasculature, increasing T cell infiltration. And bevacizumab also decreases the activity of the immunosuppressive cells, which are like MD stem cells and your Tregs. And atezolizumab, with the help of bevacizumab, it restores anti-cancer immunity, which normally tumor cells escape. So that is why they have probably a synergistic action as compared to the action alone. Moving on, please. So this is the IM-Brave 150 trial, which was initially published in EJM. It is the phase 3 trial of atezolizumab plus bevacizumab. We have an updated data for a lot of endpoints available now. Moving on, please. So IM-Brave 150 it included locally advanced or metastatic or unresectable HCC, which with no prior systemic therapy. It was randomized to 2:1 with atezolizumab 1200 mg every 3 weekly and bevacizumab 15 mg per kg, and it compared it to the standard of care, the then standard of care, sorafenib 400 mg BD. And they were continued until there was a loss of benefit or unacceptable toxicity. And the co-primary endpoints were OS and progression-free survival. The key secondary endpoints were the response rates and the predefined stratification factors were according to the region, the ECOG-PS, the vascular invasion, or baseline AFP. Can you move on to the next slide, please? Yeah, so this is the baseline characteristics. So these are fairly well matched, and you can see that a lot of patients are included from the Asian region, excluding Japan. Almost 40% in each arm are from the Asian, and you can see that majority of the patients are of viral etiology. The non-viral etiology patients are comprising of 30% of the patients, and around 40% of patients had baseline AFP of more than 400. So moving on. So this is the co-primary endpoint of PFS. The PFS with the combination arm was 6.8 months versus 4.3 months in sorafenib, with a median hazard ratio of 0.59. That is 41% reduction in the risk of death. And the 6 months PFS rate was 55% versus 37%. Next slide, please. And this is the updated analysis, which is the follow-up systemic therapy for SCC. Whether the patients were what therapy they received after they progressed on the first-line therapy, whether it was sorafenib or atezo-bev. So in the patients who were progressed on atezo-bev, lesser number of patients were able to receive the second-line and third-line therapy as compared to the patients who progressed on sorafenib. So, and there were some patients who progressed on atezo-bev. They also received immunotherapy, although the number was much less. So around 30% of the patients in sorafenib arm, they ended up receiving immunotherapy as the second line. Moving on. And this is the OS. The 6 months OS rate was 85% versus 72% when it was first published. It was not reached versus 13.2 months with a hazard ratio of 0.58. At the first analysis, the updated analysis in the next slide, please. So this is the updated OS, which was the 6 months OS rate. The 18 months OS rate is 52% versus 40% in the combination arm versus sorafenib, with a hazard ratio, with a maintained hazard ratio of around 0.6. That is like 34% reduction in the risk of death. Next slide, please. So, irrespective of the subgroup, apart from the few subgroups, the benefit was maintained in almost all the subgroups. Moving on, please, for both the OS as well as the PFS. Next slide, please. And the response rates were also higher, with a higher rate of CR as well as PR. The response rates were 27% versus 12%, and the CR rate was 18% versus 0%. Sorry, 6% versus 0%. Next slide, please. So the duration of response was also like in the updated analysis, the duration of response median was 18 months versus 14.9 months. Moving on. And this is the safety summary. So we all know the traditional side effects of atezolizumab as well as bevacizumab. Bleeding is a major concern, particularly in patients of SCC, because a lot of them have the tendency to develop varices because of the underlying cirrhosis. Although the inclusion criteria included patients who had treated varices or grade 1 or grade 2 varices. So if you moving on, please. So if you look at the safety profile as quite different, we already are aware of the toxicity of sorafenib. The side effects of atezo-bev are slightly different, more commonly associated with hypertension, fatigue, asthenia, proteinuria, which is much more common with this as compared to sorafenib. Sorafenib and both atezolizumab both can be associated with hypothyroidism. Moving on, please. So this is the rate and grade of bleeding events in IM-BRAVE were similar between the treatment arms. So irrespective whether atezo-bev was used or sorafenib was used, because of the underlying cirrhosis, the severe bleeding events related to the varices were almost similar in both the arms. Moving on, please. The bleeding events with systemic therapies were typically low in grade and unrelated to the varices, the other sites of bleeding. Moving on, please. And the other common side effects were hepatitis. Hepatitis was probably related to the atezolizumab, and it can also be seen with sorafenib as we have traditionally known, and it is also similar. Both grade 3-4 events were similar in both the arms. Moving on, please. So another important aspect, particularly when we are treating patients of HCC, is quality of life. Quality of life was maintained. In fact, it was improved as compared to sorafenib because of probably the side effects are more. And there is an early progression on sorafenib, as we have already seen in the PFS arm. So that can also lead to the deterioration in the quality of life. Moving on, please. So you can see that the median time to deterioration quality of life was 11.2 months versus 3.6 months, with a significant difference in the two arms in the patient-reported QOL based on the URTC questionnaires. Moving on, please. So this is the systemic therapy for HCC in 2021. If you're using atezo-bev, the options for you are probably going for the TKI in the second line, or maybe, so this is backed by the data that you can use regorafenib, cabozantinib, or ramucirumab. Usage of repeat checkpoint inhibitor, it is not backed by the data, but you can use desperately that combination of nivo-ipi or pembrolizumab if the patient has progressed on sorafenib. All the options are available to you. Next slide, please. So this is the NCCN guideline for HCC. We are already aware of it. I think I'm already exceeding my time. So basically, good performance status, good child-pug score. You can go for resection. If it is unresectable, or if the surgeon feels that okay, the adequate liver function is not going to be available because of the underlying cirrhosis, patient may be considered for transplant. If it is not a transplant candidate, you have to go for a loco-regional therapy. If it is metastatic or inoperable, or even is not fit for a loco-regional therapy also, then only you have to go for systemic therapy. In some cases, in unusual scenario, based on the results that are available in the guidelines in metastatic disease, you can also use it as a bridge to transplant. If you're using it as bridge to transplant therapy, there also you can use it as systemic therapy. I think most of us clinicians have used in such scenario. Moving on. Next slide. So next slide, please. These are just the guidelines. These are the ASCO guidelines. This is the ESMO guideline again. Moving on, please. So conclusion, the combination of atezo-bev has demonstrated efficacy in patients with unresectable SCC in phase 3 trial. There are no new safety concerns. The grade 3, grade 4 side effects are similar. The response rates are higher. PFS and OS rates are superior. So definitely it's a positive data in an Indian scenario for a patient. I think there are a lot of financial implications associated with this combination. But if it is a panel patient, or if he has been funded by a good insurance, if I have to use this drug as compared to lenvatinib single agent or a sorafenib single agent, I prefer to use it as a first line, particularly patients who have a treated varices or they have a very minimal varices. So thank you so much.
Thank you, Dr. Abhishek. It was a very nice presentation. And I think any questions from the audience? I think there is no questions. So thanks, Dr. Abhishek. It was a very good presentation overall.
Thank you, Dr. Tejinder. Thank you so much.
So now we will move to the next session. And the next speaker is Dr. Bharat Vashwani. He is a senior consultant medical oncologist and hematologist from Yashoda Hospitals, Hyderabad. He will be speaking on abstracts from clinical updates from ASCO 2022 2022 GU perspective. So I welcome Dr. Bharat to deliver his lecture.
Good evening, sir. Thanks for a kind invite. Thanks to Dr. Naresh, sir, Dr. Sahu, sir, Dr. JB Sharma, sir, my senior. Can I share my screen? Actually, I'm not able. Sir, are my slides visible, sir?
Yes.
And am I audible?
Visible. You can continue, please.
Yeah. So the topic that has been given to me in the next 30 minutes is what is new in this ASCO 2022 in terms of genitourinary perspective. So when I talk about it, I have divided my presentation into kidney, urinary bladder, and prostate. Now, I am not as lucky as Dr. Sandeep Batra because for me, there was no blockbuster study, means there was no practice changing like a dostarlimab study. But I'll tell you in the next 20 minutes, if you can listen to my presentation, you don't have to go through ASCO again because I have incorporated everything in the next 20 minutes. Probably I'll be answering some clinically relevant question in the next 20 minutes. So for kidney, the important abstracts were in adjuvant setting. There is a new drug which we already know, but now we have a 3-year data in a sporadic clear cell cancer. And we had update of 2 landmark studies now, which can tell us that how can be the sequencing post-progression. So let me start with my adjuvant data. This was the main data or a practice-changing study in the last year, adjuvant pembrolizumab post-nephrectomy in high risk. We all know there was an absolute gain of 10% in terms of 2 years DFS, and there was a 36.7% reduction in the risk of progression. But what we are looking at now in this ASCO was a distant metastasis-free survival, time to first subsequent drug treatment, and PFS2. So what we found out was, yes, there was the same quantum of benefit in terms of distant metastasis-free survival, around 37%, same as what he had at DFS. Time to first subsequent therapy, again, a statistically significant improvement. And more importantly, in the time to second disease or PFS2, there was again a statistically significant improvement with the reduction of around 43%. So the other parameters, even if you have progressed and you have started on a second line, this benefit of pembrolizumab continues today. I have given you 11 take-home message. This is my first take-home message. So further follow-up of adjuvant pembro continues to show improvement in all the parameters, including distant metastasis-free survival, time to first subsequent cancer treatment, and more importantly in PFS2. So now we had 2 studies, sunitinib abstract, probably not as impressive, and a pembrolizumab. Here comes my second presentation. What about giving everolimus? That study was Everest study, a phase 3 randomized study, post-op in the same sort of a patient where we have given pembrolizumab. So probably of all the studies, this was one of the most important studies. Unfortunately, a negative study. So fully resected RCC within 12 weeks. Please remember, high risk was considered as either a grade 3-4 or a T3 onwards, given 1 year of everolimus versus placebo. Now, this is important because this was a subset where you can still think of giving everolimus if the patient cannot afford a pembrolizumab. So all T3, T4, grade 3-4 tumors. Now, in a primary endpoint, recurrence-free survival, there was an absolute gain of 4% at 5 years. Unfortunately, as per a statistical significance, it should be 0.022, and it was 0.025. So it was a negative study. So there was no improvement although there was a numerical improvement. Now, the most important thing is, what about very high risk and intermediate high risk group? I have already told you, very high risk is T3, T4 or any grade 3-4. Here in very high risk, the hazard ratio was 0.79. There was a statistically significant improvement in recurrence-free survival. Unfortunately, this was not the primary endpoint, but it was some subset analysis. So why it did not succeed was because there was around 47% disease drug discontinuation in the 1 year. So again, we know everolimus is slightly toxic drug and nearly half of the patient discontinued, and probably that was why I think the trial failed. So the second take-home message is everolimus in adjuvant setting failed to achieve its primary endpoint of improvement in recurrence-free survival. It was a negative study. But I feel the ideal study probably that will be there is in a very high risk, comparing pembro in one arm and comparing everolimus in other arm. And probably there is a thought that Everest 2 might come and which will be comparing those, because it was a question mark, it was written in the discussion. So the second take home message, no improvement with everolimus, but some improvement in the high risk subset. Now, when I look into my third thing, this is a thing crowded slide of NCCN. One drug that I am not seeing, what I am seeing is IO, TKI or a mTOR. So what is the next drug and which has a long-term data which was published in this ESCO? This is a drug which is called as belzutifan, a hypoxia 2-alpha inhibitor. Now, why I am discussing is in the last ESCO 2021, there was a very good data of belzutifan. Plus, please remember that was in VHL patient only. But this is the most important data, a long-term 3 years update of this drug in sporadic clear cell RCC. So all the patients of RCC. An oral drug 120 mg to be given orally. This is a big 41 months update. Now, this is the most impressive thing. A third line or a second line response rate of 38% in the second line and 25% overall and 21% in the third line. In RCC, you don't get so good responses if you see. But the icing on the cake is a disease control rate. So a drug which gives you a 70 to 90% disease control rate in the second and third line is amazing. Now, what is more amazing is the duration response is so high that it could still not be reached at 41 months. So this is something amazing and at a very long-term data. Toxicity is manageable with anemia, fatigue, hypoxia, dyspnea, but these are lesser and it did lead to less than 5% disease discontinuation. So what does this conclude? 25% in a heavily pretreated patient. The responses were there, very, very high duration of response, even at 38 months. So if you respond for nearly 3 years or more also. And probably this is a drug which I think in this ESCO 2000 NCCN will now be included with the big data available in sporadic RCC. So the third take-home message is belzutifan, a hypoxia-inducible factor alpha inhibitor, is another drug in the treatment armamentarium of RCC. Now we have fourth drug now available after the three that I have told before. The last part of my kidney presentation. There was a similar update of two studies, a keynote 426 combining Axi with the pembro and clear study which combined Lenva with pembro versus sunitinib, and both included a PFS2. Everybody knows what is keynote 426 pembro Axi versus sunitinib. We know the primary endpoint. There was a statistical improvement in PFS, OS. At 3 years, this benefit continues to remain. But what was new was PFS2 analysis and what was given in the subsequent thing. So when you look into PFS3, it is 40 months, 16-month PFS1, PFS2 40.1 months. Now, what was given was in a second line, when you gave pembro, actually majority of the people took a VEGF TKI. But it was not the case when you give sunitinib, where it was equally distributed between IO and a TKI. What about PFS2? Again, the PFS2 is highly impressive. When you look into favorable risk or intermediate or poor risk, the benefit remains the same, although the quantum of benefit, see on the right side, is much better. Around 17% absolute benefit at 3 years, and in terms 12 months absolute benefit. But even in good risk category, the benefit continues, so you should use it. irrespective of any of the risk factors. So the 4 take-home messages: with the follow-up of 42.8 months, combination of pembro-axili continues to show a better, PFS2 significantly better, and patient who progressed on combination therapy took VEGF TKI on progression. So second line, most of them took VEGF TKI. Now, when you look into clear data, again, len pembro versus sunitinib. The right side shows probably the best result, 23.9 months in terms of PFS, which is statistically significant, and 0.39 hazard ratio. And in terms of overall survival also, at the first interim, it was better. So this update looked at PFS2, subgroup analysis of PFS2, and what they took in the second line. So when you look into second line, again, those who took len pembro took anti-VEGF in the second line, whereas sunitinib, it was equally distributed between either a VEGF drug or an immunotherapy. Now, when you look into PFS2, again, it was statistically significant. Although if you see the hazard ratio, it is 0.50, 0.39 was PFS1, PFS2 is 0.50, but this benefit was across all risk subgroups. So the 5th take-home message is, again, at the longer follow-up, PFS2 significantly better as compared to sunitinib, and those who progress again on this took VEGF TKI on progression. There comes my million-dollar question. What should be the sequence? What should be the ideal second line? So apart from these 2 studies, if you look into the data, there are multiple TKIs which has been used post IO progression. Overall response rate probably is between 19 to 45, most impressive in cabo and XZ, and a PFS of high of 5.6 to 9.3. So 3, I have told you updates, probably some things that you should incorporate and some tips in your practice. What about urinary bladder? There are 2 new drugs. Again, you listen to me, you can keep this, and because in future you will hear a lot of these things about new drugs. That is why I say it is lucky to be a medical oncologist. A new drug in BCG refractory disease apart from pembro. There was an update of Javelin, and now HER2 is a flavor of the season with the data of deruxtecan in low. If you see, there is the data is even more impressive in bladder cancer in a low HER2 with the new drug. All of us know that last year this was a publication, pembro in BCG refractory. Please remember the landmark was 1 year complete response rate was 90%. And when you look into the other trial, what I'll be telling, it is 3 times better with the as compared to pembro. So now we have a blockbuster new drug combination which shows better CR rate than that. So this was a pivotal study which combined BCG in those who failed with interleukin 15 super agonist. What does BCG 15 do? It boosts the immune system which has already been primed by BCG. So there is activation of natural killer cell, and that causes memory and durable complete response as seen by this very impressive data. So 2 subgroup of patients. One is carcinoma in situ, and second was a papillary carcinoma. Please see, the left hand is the primary endpoint was complete response, and in situ, in papillary, it was DFS. It was 6 doses followed by maintenance. 71% complete response at the end, with a complete response at 12 months in half of the patient. This was more than 2 years you had a response wave in this drug. Now compare your data with pembro. CR at 12 months is 45% versus 19%. So now you have a combination which is 3 times better than this, and probably this will be something that we need to validate, and probably that may become better drug than pembrolizumab. So better CR rates and CR rate at 1 year with this combination as compared to pembro. Now, when you look into the other cohort of papillary disease, a very, very high median DFS of close to 2 years, which is far better than the historical control. So the 6 take-home messages in a BCG refractory disease, we have an exciting new combination of interleukin 15 super agonist with a BCG. But however, we should be cautious because probably if we can have a phase 3 trial in this rarer BCG subset, but yes, a very good data available now. This is a sponsor slide because I have to tell something about the update of Javelin 100 study. What was new was what was the drug given in post progression, and I think this is something that is interesting. And what was the Asian subset analysis? This is all we know, that there was a statistical improvement in PFS, nearly more than twice the improvement in PFS with a reduction in progression by 46%. But more importantly, first data in maintenance setting, which showed that there is a statistical improvement in OS in those who had either a CR, PR, or stable disease post 4 cycles of chemo. Now, this is important. One thing is only half of the patients who took this maintenance went down to the, probably you can say, a second line. And they were divided between re-challenge with platinum. A very few took a PDL1 again, and then there were multiple other drugs, including Pacli, Infertumab, Gem, Dosi. Now, when you look into the survival, which subset had the best survival? So, a re-challenge with second-line platinum-based chemotherapy, they had the best survival of 22.5. So, something that I also tried to look into why it was better than all the other novel drugs. Now, when you look into the Asian subset, it was 21%. This quantum of benefit in terms of in OS and in PDL1 in both the subsets was same as compared to rest of the Asian subset. When you look into the response rate also, so more patients achieved the objectable response and disease control. So this data was more or less similar to what was non-Asian, unlike some of the study where Asian people did not do well. So the 7 take-home messages, long-term follow-up Javelin 100 suggests that continued benefit with maintenance avelumab, re-challenge with platinum gave the best OS, and probably the results were consistent with the Asian population. The last part of my urinary bladder, a very good or a flavor of season again. Should you start testing HER2/neu also in the bladder cancer? We have tested in most cancer, breast, you have stomach cancer, you have rectal cancer. The answer is yes, a big yes, that I'll be telling with the new data available. Is it uncommon? The answer is no. Around 32% has HER2/neu. I see 2+, 4%, 3+. Why am I mentioning 2+? Because the data is 2+ also, it is 50% response rate with this new wonder drug, and you'll see probably we'll have a new option available. So what is this drug? So the new drug that I have mentioned is disitamab, and it is an antibody. Basically, if you say disitamab, this has the same active load which was in enfortumab vedotin, monomethyl or SNE. The target is HER2/neu, but a different site from trastuzumab. The linker is a cleavable linker, so the best effect is a bystander effect. So this disitamab, just look into the data. For 3 months, I see the response rate was 62% in the second and third line. Even if your IHC was 2+, your response rate still was 39.6 with the overall response rate of 50%. Now, when you look into disease control rate, around 80%. Now, this is most important. Even in 1+, your response rate was 38.5%. And if I go back to the data, in 1+ also, there are around 92% of the patients. So probably in future, you will see this drug probably in any of the HER2/neu. Of course, the quantum of benefit remains more in if it is 3+. There is a good data which says that the overall response rate was maximum and the disease control rate was more than 90% when you combine it with immuno-oncology drug, this drug. So in future, you have 4 phase 3 data and probably you will have this drug available in clinical practice. The toxicities are mostly neuropathy, some hepatopathy, some rash, and some hyperglycemia. But this toxicity is different from other drug antibody conjugates. So my 8 take-home messages in the last 3 years, we have 3 drugs now. Disitamab vedotin, enfortumab vedotin, and secukinumab govitecan. And probably you will see lots and lots of new drugs coming, targeting, which are impressive responses, and probably the overall survival will keep on increasing. The last part, and another 3 to 5 minutes. What is new in prostate? So again, there is an update of INZAMAT study. I was more interested in knowing about lutetium versus cabazitaxel, which I feel is more appropriate than a vision where the other arm was weak. And in the same year now, we have 3 studies in first-line CRPC, which combine PARP inhibitor with androgen receptor antagonist. So this is one of the best slides I saw. In a nutshell, what are the trials in hormone-sensitive prostate cancer? But our topic of interest is INZAMAT study. Now, everybody knows that it was hormone-sensitive testosterone suppression with enzalutamide. What we got update was the updated survival, effect of prognostic, and more important, where you should use a triplet therapy. Now, what was interesting was in those patients where the drug was not used, probably placebo was there, still had an OS of 73 months. Probably this is the best survival in the control arm, which I have seen in all the studies till now. But when we have given enzalutamide in HSPC, there was a 10% absolute gain in overall survival. This was in spite of the fact that 76% had to go either ABI or INZA when they crossed over in CRPC. 45% patient took docetaxel. The best benefit of INZA came in low burden, low volume disease, but it also benefited in high burden with or without docetaxel. The most important thing was, where should I give dosi? So what they found out was the highest risk subset, synchronous high volume disease, combination of INZA and docetaxel, there was a clear benefit in terms of all the parameters. So again, it has again reiterated that if you are fit, if you have a high burden synchronous, think of giving a triplet. So my 9 take-home messages: enzalutamide added to hormone suppression, provided clinically meaningful improvement in OS, greatest benefit of triplet in poor prognostic subset, that is high volume synchronous in patient fit to tolerate triplet. Important data. For me, lutetium-177 therapy is one of the best drugs post chemo and this newer non-steroidal drugs, including INZA and ABI. But this was the main better because the comparative one was Cabezi, which is probably an effective drug. This was an update at 3 years of survival. In the last year, we have seen that lutetium PSMA is better with as against cabazitaxel in terms of prolongation of radiographic progression-free survival and PSA progression-free survival. Unfortunately, what they found out was there was no improvement in overall survival. So this was a dampener. So probably they have not mentioned the reason, but I think the main reason will be that people could took this drug in the later line. Now, what was important was, this is the most, where should I think of giving a lutetium PSMA earlier than Cabezi? So for patient with a PSMA PET SUV more than 10, just look into the 50% reduction in PSA, 91%. See this, the waterfall plot. The odds ratio of response in those with a PSMA SUV of more than 10 is 12 points. So 12 times better chances that it will work better than Cabezi. So the 10 take-home messages for patient with castrate-resistant prostate cancer with high PSMA PET sensitivity of more than 10. Think of giving lutetium PSMA better than Cabezi because it has a better PSA response, better PFS, better quality of life, favorable safety profile, but with equal survival. And the last part of my presentation. In 1 year, we have seen 3 trials now in a first-line castrate-resistant prostate cancer, which have combined PARP inhibitors with a AR antagonist. In this ESCO-GU, you had a Propel and a Magnitude, and now in this, we have a BRCA-away study. Now, for simplicity, I have made it in a single chart. All these studies combine either a abiraterone acetate with olaparib versus a single agent abiraterone, and in Magnitude, it was niraparib with abiraterone. Now, when you look into the population, Propel was unselected, by the other 2 was selected. In BRCA, it was BRCA1, 2, and ATM, whereas in Magnitude, it was the entire HRR. Now, the results, if you see, all 3 shows the same thing. There was a statistically significant improvement in radiographic progression-free survival when we combine both agent versus abiraterone acetate in the single agent. The important thing, what about toxicity? So the toxicity was tolerable. It was 5 to 15%, commonly anemia and venous thrombosis. Please remember, so this is a good combination, but manageable. But we are yet to get the OS data. One of the most important questions, what profound suggested that the magnitude of benefit is because of BRCA2 in profound, but Magnitude again looked at all these parameters again. But what was heartening was, if you see PAL-B2, check, and HIDEC2, in all these subsets, there was a statistical significance in terms of radiographic progression, TCC, everywhere. So apart from BRCA2, BRCA1, I think PAL-B2 last year, breast, you have an impressive data. In PAL-B2, CHEK2, and HIDEC, I can still think of giving my PARP inhibitor with an androgen receptor antagonist. So this was an add-on for me. So if I have to summarize my last take-home message, strong evidence suggests that there is definitely a synergism, what we call partners in crime. Combination of AR and PARP can be synergistic. Probably we know maybe that benefit extends beyond BRCA mutation subset in terms of, I told you, PAL, CHEK, and a HIDEC2. But again, we need to be careful because we don't have a long-term OS data. But yes, probably in the future, you will see with the acceptable toxicity, we may combine this drug earlier because earlier the better for PARP inhibitor. So if I have to summarize, I have given you 11 take-home message in 3. If you can go through this again, probably you have covered or you don't have to read anything. And I end my thing with the famous quote of Socrates. The secret of change is to focus all of your energy, not on fighting the old, but on building the new. I thank organizer for a kind invitation.
Thank you, Dr. Bharat Vashwani. You have given a very excellent presentation with so many updates in a short time you have covered. Any questions from the colleagues who want to add something or want to ask something from Dr. Bharat?
Yeah, Dr. Vora here. Can I ask a
Yes,
question?
sir.
Sir, please.
Bharat, first of all, awesome. I was seeing a patient and I said, just stop. I want to listen to what Bharat is saying. Bharat, it was actually an amazing overview. I would want your slides and they were amazing.
Thank you, sir.
My question to you was, there was a lot of criticism about Propel and magnitude, especially Propel. And it was presented, the discussants, and there were a lot of reviewers. They said that somewhere the company sponsored, both the trials were company sponsored, and somewhere they were in a hurry to expand the label as much as possible without overall survival data. So my point to you, Bharat, is that tomorrow, if a patient comes who fits into Propel study inclusion criteria, would you offer olaparib or would you wait for overall survival data? This is a million-dollar question going around.
Sir, I will not offer it. Propel, I think so. It included all comers. Sir, my conviction is still true that there is a benefit. Major benefit is BRCA2 only. BRCA1 slightly less, but what I change is maybe there are that 3 other subsets which you might have a benefit more. Again, that is again a questionable thing. But sir, again, I fully agree with what you said is a company-sponsored study. But again, and I think that we should not use it again. But only thing is probably combination might be better because some of the patient may not take the other drug in the other line. So,
so my point was Dr. Somani also wants to say something, but Dr. Somani, just 30 seconds more. I do not agree with what they have said, Bharat, because today in my panel I am going to discuss about the triplet in HSPC. Agar hum triplet use karte hai, HRPC hota hai, it's a very short duration by the time patient dies. Okay, and if you have a data, if you take the magnitude and Propel, both BRCA positive patients, the hazard ratio is close to 0.5, 0.6.
Yes, sir. Excellent.
I would not wait for OS data in HRPC where the survival anyway is much less, and I would offer them olaparib or niraparib, whatever they can afford. That is how I look at it. Somani sir, to you, sorry.
So just to counter the Dr. Bharat, his last slide was about the Socrates that don't criticize the old, go for the new, and he himself don't want to use it. And so many breakthrough treatments. So many breakthrough treatments are based on the PFS. We don't wait for the overall survival. So Dr. Bharat,
my point was like, sir, in all comers we should not use.
All comers, he said.
You should use in.
He said in all comers.
No. The BRCA are only few percentage.
Sir,
and why to deprive those one patient and the next patient? No.
Sir, 20 to 25% will have either BRCA or HRR, sir. Prostate. We are not doing it routinely. Once we do it routinely,
probably from HRR, actually, I may start using it in HIDEC, CHECK, and PAL-B2 also. Maybe that was something that I did because Profound showed that the main was BRCA2 and BRCA1. Only thing is, sir, for all comers, then I still believe the entire quantum of benefit is driven by this BRCA and some unknown subset. But this benefit is not so much that you should change your practice and give olaparib probably in all the things. That was my thing. But because if OS shows things probably in those subsets which are non-HRR, I may start using. But at present, sir, I think the data, still I am not convinced with that.
So just 30 seconds only with permission. Suppose it's available with the 5,000 rupees. Will you use it or not?
Difficult question, sir. Again,
sir, ये $1 million question हर एक panel में होता है.
So from $1 million, if suppose it becomes a 1,000 rupees question, 5,000 rupees only.
Sir, probably some tempting, but still I'll think so for a non-HRR. I may wait, sir. Maybe I'll be very truthful, sir. Thank you, sir. So kind of you for it.
Thanks, Dr. Bharat. It was a nice overall review by the colleagues also. So now the next session is by Dr. Sushant Mittal, who is a senior consultant medical oncologist from Action Cancer Hospital, and he will be delivering his talk on darolutamide in management of metastatic CRPC. So I please invite Dr. Sushant Mittal to kindly deliver his lecture.
Thank you, sir, for the kind invitation. I'll just share my screen and
please.
So after discussion of about 3 to 5% of patients who might be HRR positive in prostate cancer in metastatic setting, I'll be talking about another 3 to 5% of the population who is not metastatic. They have progressed, but they are castrate resistant and are not metastatic. So that percentage of population is very less who have progressed and are not metastatic and are hormone resistant. So that's what this drug has come up with, darolutamide in non-metastatic castrate resistant prostate cancer. So prostate cancer disease progression, we all know that we have some share of patients who will not behave and will progress during the course of their disease. And these patients will be hormone sensitive or hormone resistant prostate cancer. And the patient with non-metastatic castrate resistant prostate cancer can have their rising PSA levels, but are mostly asymptomatic from their cancer. And for such patients, how to deal with changing the therapy, that's what this drug is trying to show us. So patients with shorter PSA doubling time are at greater risk of distant mets and therefore have a high urgency for treatment management. And in such patients, PSA doubling time is a strong predictor for the speed of disease progression in terms of development of metastasis and overall survival. So patients with shorter PSA doubling time less than 10 months are at greater risk of distant mets, and it has been shown in this graph also that less than 10 months is chances that the disease will progress faster. So we all know that metastases are associated with decreased survival and quality of life and increased healthcare costs. So 1/3 of non-metastatic CRPC progresses to metastatic CRPC within 2 years of ADT alone. The risk of annual all-cause mortality increases after progression from non-metastatic to metastatic, and the patient with prostate cancer, 5-year survival is reduced after the development of metastasis. And bone metastasis significantly lowers the quality of life and increases healthcare costs. So we need to delay the patient from non-metastasis to metastasis. So M1 disease on PSMA PET should not disqualify patient with non-metastatic CRPC diagnosed by conventional imaging from receiving this newer molecule. So patients with metastatic disease report a decreasing ability to maintain their lifestyle. We all know this. So the key therapeutic goal of non-metastatic castrate-resistant prostate are to prolong survival without disrupting patients' daily lives due to treatment-related adverse events. So extending OS is one of the goals. Maintaining the quality of life is another goal. And the PSA to be controlled with related anxiety has to be allayed so that patient has emotional good quality of life also. So with this, the Spartan and the Prosper trials were designed, which was similar to RMS, and the patient population were non-metastatic CRPC, PSA doubling time less than 10 months with good performance status. In RMS, about 1,500 odd patients were there with darolutamide with ADT versus placebo with ADT. Spartan was apalutamide with ADT versus placebo and ADT, and Prosper was enzalutamide plus ADT versus placebo plus ADT. And the primary endpoint was metastasis-free survival, and the key secondary endpoints were overall survival in almost all the trials, time to brain progression, time to cytotoxic chemotherapy, and time to first symptomatic skeletal event. So daratumumab significantly extended overall survival beyond that of placebo. As we can see, the green line is for daratumumab, and the hazard ratio of 0.69 with confidence interval of 0.53 till 0.5 or till 0.88, and significant p-value that there was 31% risk of reduction of death in such category of patients, and these patients received subsequent life prolonging therapy. So primary endpoint treatment with daratumumab more than doubled the median metastasis-free survival compared to the placebo, as we can see, and the graphs are separating from the beginning and continues to do so. So 40 months versus 18 months, which is significant, with 60% risk of reduction of metastasis-free survival, which is quite significant. And the endpoints of meaningful clinical benefit to patients and physicians was significantly improved by daratumumab. So secondary endpoint, the final analysis shows that time to pain progression was better, time to first cytotoxic chemotherapy, hazard ratio of 0.58, and time to first skeletal related events were hazard ratio of 0.48. So in all those parameters, which are very important for the quality of life in any prostate cancer patient, has shown that addition of this therapy is has significantly improved the overall survival with quality of life. Treatment with daratumumab improved PFS and time to PSA progression. The exploratory endpoint of primary analysis, the PFS, if we see it's 36 months versus 14 months, almost 3 times it has improved, and time to PSA progression almost 4 times or 5 times it has improved, leading to good quality of life again. So more patient had a significant PSA response with daratumumab than placebo. We can see the waterfall graph, significant decrement in the change in the drop in the PSA levels can be seen with this newer drug. Quality of life, if we see all of them, but the bowel symptoms, the hormone related symptoms, incontinence, sexual activity, sexual functioning, urinary symptoms, all of them favor daratumumab except for hormone related symptoms, which is favors placebo, but these was also manageable and not of significant grade. So the daratumumab with non-metastatic CRPC generally are asymptomatic from their cancers and have good quality of life. So it is important to maintain their lifestyles. So it has shown that quality of life was maintained. The bowel and urinary symptoms were also not had not worsened with the addition of this drug. So bowel symptoms such as stool, bloating, blood in stools, interference with daily activities, and urinary symptoms of frequency, urgency, interference with daily activities, all had significantly improved and hence favored daratumumab. So permanent discontinuation because of side effects, the rate of discontinuation as a direct measure of each agent's tolerability and are not impacted by differences in the frequency of reporting schedules across the study. So daratumumab, it was just about 8.9%, which is not significant. Incidence of side effects that between the treatment arms, fatigue is definitely one of the side effects which we see because of this therapy, and it is because of the decrease in the hormone testosterone levels. The other side effects are manageable. So the CNS related side effects, which are very important, why we are discussing this, because the enzalutamide and epalutamide have CNS side effects such as cognitive dysfunction, seizure disorder, depression, and dizziness, which leads to fall. So all these were significantly reduced. I'll show you in the next few slides. So majority of these patients are elderly and are on concomitant medicines such as for ACE inhibitors for blood pressure control or lipid modifying agents, antithrombotics. So the drug-to-drug interactions with these analgesic and cardiovascular drugs was not significant and did not lead to any additional side effects or any additional toxicity because of drug-to-drug interactions. So as I was saying, the daratumumab displays low blood-brain barrier penetration compared with enzalutamide and epalutamide in preclinical models. It is just about 8% compared to 85% and 80% in other two drugs. And that's why these cognitive dysfunctions, seizures, depression, all these were significantly less with darolutamide. It did not show any significant change in the gray matter versus placebo, as can be seen on this graph. So current treatment guidelines do say that if the PSA doubling time is less than 10 months, apalutamide is category 1, which is not available in India. Darolutamide is category 1, which will soon be available. Enzalutamide, the trials are still going on, and we'll see how the drug performs. But the side effect profile, we are sure that darolutamide is better compared to other drugs. So the recommendations are strong recommendation for the use of darolutamide in such category of patients. So to conclude, the efficacy, darolutamide significantly reduces the risk of death by 31% in men with non-metastatic CRPC. Darolutamide significantly improved clinically meaningful endpoints, including delay of the pain progression by 15 months, reducing the risk of initiation of cytotoxic chemotherapy, and reducing the risk of skeletal-related events. It also demonstrated a median PFS of metastasis-free survival of 40 months, which is more than the double median PFS seen with placebo. The safety, darolutamide continued to show only less than 2% difference between the darolutamide and placebo arms of most of the side effects. And quality of life is significantly improved with darolutamide. It did not further deteriorate. So thank you so much for patient hearing. Back to the organizers.
Thanks, Dr. Sushant, it was a very nice presentation and appears to be a good drug in the coming time. Any questions to the Dr. Sushant? I think there is no question. So thanks, Dr. Sushant. It was a very nice. You came and gave a very good lecture. Thanks, Dr. Sushant. So now we move on to the next topic, and now it is a panel discussion. And the moderator is Dr. Amish Vora. He is the director and co-founder of the Hope Oncology Care Clinic at Delhi. He is a well-known oncologist of Delhi. So over to Dr. Amish Vora. He will be having a discussion on locally advanced and metastatic prostate cancer. Dr. Amish, please.
Thank you so much. The panelists whom I have, do we have all the panelists with us? Dr. Amit Joshi. Do we have Dr. Amit Joshi? Dr. Deepak Dapkara?
Yes, sir.
Dr. Deepak is there. Dr. Hemant Goyal? Do we have Dr. Hemant Goyal? Dr. P.N. Mohapatra?
I'm there.
Dr. Mohapatra is there. Dr. Amitabh Singh?
Yes, I'm in.
Dr. Amitabh Singh is there. Dr. Amit Joshi, do we have him or not? So we have one surgeon and two of the medical oncologists right now in the panel. Is that correct?
Dr. Amit has joined.
Amit Joshi?
Yes,
Yes, Dr. Miss, I am there.
Okay, perfect. So we have three medical oncologists and we have one surgeon. We don't have Dr. Hemant Goyal as yet. Is that correct?
I've joined, sir. I joined.
Okay, Dr. Hemant Goyal is also there. So we have two surgeons and three medical oncologists. That is what in the panel we have. So, we have 30 minutes, and I think in 30 minutes, if we reach one consensus, it would be great how I look at it. So the topic of my panel discussion today is more the better. That is what we are looking at. And we are going to discuss the three trials, that PEACE-1, ARASENS, and ENZAMET. We will start with ENZAMET because that was the earlier one which was reported. Then we'll go to PEACE-1 and then we'll go to ARASENS and we will see. So before we embark on the journey, Dr. Hemant, if you can keep your video on. Yes, Dr. Hemant, natural history of hormone-sensitive prostate cancer. You see CRPC, CSPC, whatever you want to call it. The natural history, which is the best period for patient?
So the best period is obviously when he is hormone sensitive.
How is it? Because this has an important connotation in what we are going to discuss, and that's why I'm saying that why HSPC is more quality of life better compared to HRPC.
So basically, why HSPC that time the quality of life is better in patient? Because sir, basically we first of the is the longer we prolong this HSPC state, because that is in our hand. Once what I have seen, once he's in HRPC, whatever we try, then the progression is very difficult to halt that progression or to reverse that. Only we can delay a bit. But in HSPC, the quality of life is very good. He is very less symptomatic, and he is very much more compliant also. We can offer him more aggressive treatment also. He has better general condition, so aggressive treatment can also be given. Once he is in HRPC, very limited options are there.
So, Dr. Hemant, you are absolutely right. According to one survey where people had followed the natural history, the 90% of the symptoms happened during HRPC, and the 10% of the symptomatic life was during HSPC. Dr. Amitabh, you are an oncosurgeon. Tell me, if I say that the drug, a person of prostate cancer metastatic disease is going to live for, say, 6 years. You add a drug, the person is again going to live for 6 years only. The survival is not going to change. But HSPC period would increase. Would you be for that drug, or would you like to see overall survival when you look at any new drug?
So definitely, I would like to have a longer duration of HSPC state, but our primary goal would be to increase the overall survival also, because at the start of the treatment, patient they are mainly focused on the overall survival, because their main concern is overall survival, not HSPC state, because they have a lot of liability for the families and some other issues in the family. So they see their overall survival as a primary outcome. So whatever treatment they are getting, whether it is increasing their overall survival is not, is the, I think, most important for the patient. And if any drug which is increasing the overall survival, it will definitely increase the HSPC duration also.
It will also increase that. Dr. Amit, would you agree with Dr. Amitabh Singh?
I think, yes, in this situation, the initial phases of quality of life is important, and definitely with the availability of the newer therapies and the intensification of therapies has definitely helped in this. So I agree with him.
You agree with Dr. Mohapatra? The new drug does not increase overall survival, but increases HSPC period. A person, say 54-year-old gentleman working in a multinational company and earning a good 5-figure salary, you tell him that you're going to live for 6 years, but first 5 years you are going to be able to go to office, but last 1 year it may be difficult. Versus if you don't use the new drug, it may be 3 years, 4 years, and then 2 years. What is your take on this?
I think in the metastatic disease, quality of life and then quantity both are important. So if somebody have a quality of life, then they can afford the drug, and the drugs are available with good quality of life. Then it's my take will be the patient more in the HSPC more better. Because
HSPC more better. Dr. Deepak, do you have anything else to add?
No, sir.
No. Okay. My take is that, I would definitely go for HSPC, because whoever are patients I have seen of prostate cancer, they have excellent quality of life as compared to HRPC. So if the overall survival data is not there or is immature, but if there is an HSPC period is prolonged, I think that is practice changing for me. That is how I would look at it. Dr. Amitabh, a lot of new trials have added radiological progression-free survival as the primary endpoint. Do you agree with this, or would you like to have some other primary endpoint before you say, okay, yes, this drug is working on this?
Okay, so actually, a lot of trial has been using a lot of surrogate markers, surrogate outcomes. So this is just to reduce the cost of trial, just to get the results early. Because if your primary outcome is overall survival, then you need to see that trial for at least 4 year, 5 year. So in most of the trial, apart from few trials, even if they have observed for the secondary outcome like progression-free survival or radiological progression-free survival, and ultimately on the secondary analysis, they have been found to have increase in oral survival also, apart from few trials only. So like there is a lot of debate about all these surrogate markers or surrogate outcomes, whether they should be applied or not in the clinical trial setting. But I agree, if like there is a robust outcome, if there is a very good hazard ratio for some particular like surrogate outcome, then I think it is a still good outcome.
Okay, perfect. Dr. Amit, would you pass in your ethics committee prostate cancer new drug trial if RPFS is the only primary endpoint?
I think the other important point regarding is this, that the PSA progression, if we take the PSA progression on only, some patient may have a radiology, which we have seen commonly, that some patient may have a radiological progression without PSA progression. And second thing is that the OS may be influenced by the subsequent therapy. So the OS may not improve as quoted by this. So I think, and if you look to the Aberatron also trial, the CRPC trial in Aberatron, so this have so RPFS from my point of view is a decent endpoint, and it's a robust endpoint, and it has just the test of time it has seen. So I will comfortable with the RFS.
Okay, you are comfortable. Dr. Mohapatra, you wanted to say something?
I think prostate, like HER2 positive or HR positive breast cancer, it is actually radiological progression-free survival is a good endpoint. Actually, if you see OS, it will take a long time to get a OS actually. So in like breast also, there are alternative ways of actually to see the trial actually. And radiological progression-free survival is a good endpoint actually.
Right.
Not the only endpoint.
Taken your valid point, and I think panelists all feel that RPFS may be a good way to begin with, but they would like to see other endpoints also. That is what I take from that. Dr. Hemant, in your practice, does PSA rise always correlate with radiological progression? And how do you define skeletal related event? You know, one of the very major, one of the endpoint is skeletal related event progression. In clinics, how do you take this?
Sir, like in my practice, sir, it is not very, like it's not always that with PSA progression, there is radiographic progression, so radiological progression. So that is not always there. Most of the time, initially there is PSA progression, and with due course of time, there is radiological progression. Often these patients are already multiple metastatic sites, especially bone. So once we have lymph node metastasis, then I have seen the patient going into CRPC state. So initially in my practice, there is some PSA progression, then there is radiological progression. And I think second thing is your skeletal related events. So the most common symptom is bone pains actually. The symptomatic, the patient becomes symptomatic for bone pain, and initially he's like responding to normal NSAIDs and anthracyte, but later on we have to go for more systematic treatment. So the best thing is what we advise is a good physiotherapy to the patient, and our drugs to prevent the skeletal related events like calcium, vitamin D3, and all our agents that we have to give. So that is my take on it.
Understood. Dr. Deepak, how do you define skeletal related event in your practice?
So it is either bony pain or need for radiotherapy or need for surgery or cord compression.
Okay. But commonest thing would be the bony pain, which is not responding to common NSAIDs, or any new bony pain, you take it as a skeletal related event. Dr. Deepak, any new pain, bony pain, you take it as a skeletal related event?
Yes, sir.
Okay, perfect. Dr. Mohapatra, you have something else?
Yeah, it is actually clinical correlation. You are seeing a patient, you are seeing some pain which is not going with analgesics, common analgesics. Then you go for a scan actually, and especially some patient, but PSA is rising actually.
Okay. Okay. Right, I got it. Point. So, the PSA rising with radiological progression is almost synonymous if somebody whose PSA earlier was high, and skeletal related event normally is any bony pain which is new, which was not there earlier, and which does not go in 5 to 7 days time is what normally people define as. So let us start with, in this background, let us start with Enzamet study. Enzamet study, as you all know, was a plenary session in ASCO 2019. And this was a study where ADT or testosterone suppression, even surgery was included in this, with standard NSAA, that is bicalutamide, nilutamide, and flutamide. And in the experimental arm, instead of NSAA, enzalutamide 160 milligram per day was given. So let me, Dr. Hemant, would you, what percentage of patients in your practice go for ADT versus bilateral orchiectomy? I remember in AIMS when I was doing my DM, there was, in the urology OPD, there was a minor OT which was created, and patients coming from far away, you do bilateral orchiectomy, give them bicalutamide, and send them back and tell them that you come back after 1.5 years or 2 years. Today, how is it practiced?
So, sir, now ADT as monotherapy is almost, we don't practice that as monotherapy, like bicalutamide as monotherapy is almost obsolete. It's very rare we give as this bicalutamide as monotherapy. So now common, like your question is medical castration versus surgical castration. So now, sir, that depends on the economic status of the patient or whether he's on some empanelment. And we explain both the procedures. Personally, if he's diffuse, he's high metastatic load, then I prefer a surgical castration. If there is a low metastatic and I see intermittent ADT at any point of time in future, I feel so I prefer to give him medical castration.
Prefer to give medical castration. Get your point, Dr. Amit.
Yes.
An 82-year-old gentleman with some cardiac comorbidities, performance status of 1 hovering towards 2. Would you add any abiraterone or enzalutamide, or would you give only ADT to this patient?
So I think if a patient has a history of CAT but otherwise fit, so and especially if it's a high volume disease, I will like to add.
Low volume disease. Let's assume low volume disease, not high volume
disease. We have to see what is the how bad is. So we have to decide whether the patient will die because of the prostate cancer or because of the cardiac associated cardiac comorbidity. If his cardiac is otherwise well, with after CABT or after say the bypass and angioplasty, if he's otherwise fit and ejection fraction is anything above 45, 50, I will like to add angina in this patient. But if his ejection fraction somewhere around 25, 30%, already having some gestational dyspnea, symptom of cardiac failure, then definitely we don't want to push for enzalutamide in this case. So otherwise, I will like to add angina if there is no such contraindication from the underlying disease cause.
Okay, Dr. Amitabh, this is very interesting because, just 1 month back in one of the prostate cancer, there was slightly different thought process. Dr. Amitabh, 82-year-old, same gentleman with cardiac comorbidities, left ventricular ejection fraction of 40%, and there is a very low volume metastatic disease. Say 1 nodule, but there are 2 bony lesions are there, and there's mild bony pain, minimal symptomatic. Would you ever tell the patient for observation only, or you would still give ADT to these patients?
No, if he is having a metastatic disease, even if a low burden disease, and if he's symptomatic, then I would definitely consider him for actually ADT, giving me ADT. But if suppose like patient is totally asymptomatic, his cardiac status is very poor, then we can discuss watchful waiting for this patient. Otherwise, if like his cardiac status is relatively good and he is having a bone pain, then definitely I would consider to giving him ADT. And rather than adding ADT, this newer drugs like abiraterone and enzalutamide, we can consider giving him SBRT to the bone also.
SBRT to the bone also. And so there are two large. I today because it was ASCO 2022 or GUA 2022, I didn't put that slide. A very nice real world studies done where for 14 to 15 months watchful waiting can help patient tide over the crisis before patient becomes symptomatic. And I think that is something which we have forgotten in our practice. And there can be select number of patients who can be for watchful waiting. That is what I wanted to give that. Let's look at enzyme study. And
this is in metastatic setting. You are saying that patient having a metastatic disease, you want to wait for 40.
Patient has yes, Amit. Patient has HSPC, 82-year-old gentleman with ejection fraction of say 42-44%, and has two bony lesions, very minimal pain, PSA of 11. That is what these are the group of patients which I am talking about. Watchful waiting, or maybe just give EBRT to the painful site.
And no ADT, neither.
I'm asking, would you go for watchful waiting or not? You are the panelist. You are supposed to answer.
In a metastatic, so in a metastatic setting, 40-45% is not that bad patient with the availability of newer and newer cardiac drugs. I think we may discuss regarding the adding enzalutamide or abiraterone, but minimum ADT I will like to at least.
You would like to give it. Okay, perfect. Point very well taken, Amit, and I completely agree. As I said, there were few trials of watchful waiting. Maybe I can share with you, and some of them, one of them had a follow-up up to 2019. I will share with you. Anyway, let's move forward. The enzyme study was probably the first study where the triplet was used because November 2014, they amended the study and they said that they can allow early docetaxel to high volume disease because the chartered study came into the picture in 2014 and they did not want patient to be deprived of docetaxel. And as a result, patients, 44% of the patients received docetaxel in enzyme study. This was the overall survival in all the patients put together. That this was their proportion of patients alive at 36 months or 3 years. I feel this is too short, and you can see that there was no median reached as yet. But as Bharat presented, now we have a longer 72-year follow-up, and enzalutamide stands for that. The secondary endpoints were progression-free survival, and as you can see, a very nice graph separates time to PSA rise, time to clinical progression. Both were highly statistically significant if we give enzalutamide. Now, this was little surprising to me. If the patient has taken docetaxel, this patient could have been in bicalutamide plus ADT arm also, or this patient could have been in enzalutamide plus ADT arm also. And if you see in the first graph, what I have seen, the overall survival in this particular group of patients where there is 71% high volume, there was no statistically significant difference in overall survival. But if you see in a high volume, there was no docetaxel, enzalutamide added to the survival of the patients, those who received ADT alone. Amit, coming to you. Do you find this little surprising about the triplet therapy? Because we are going to talk about PEACE and ARASENS very quickly. Do you find this surprising that overall survival was not different? Or do you think that docetaxel in the placebo arm overtook the benefit which was seen by enzalutamide?
I think that is one of the weakness of this study. So if you look to the other two trial data, definitely this was surprising. We were expecting that like in other two trials, this would have also come up to be positive, but it was negative. So the other possible hypothesis that whether the darolutamide or abiraterone may be some way indirectly more effective, which may have made the trick. But definitely we were not expecting that at least patient who received the triplet would have better OS that we were expecting.
Okay, to me it was very surprising, and I don't have an answer to that why this happened, because now we have peace and Arasan study. Dr. Mohapatra, after this enzymatic study in 2019, did you change your practice and did you start using more and more of abiraterone and enzalutamide in your practice?
Now we are actually, all the patients we are discussing about adding enzalutamide and abiraterone. And about this study, actually, this study was never powered to see the difference with docetaxel, post-docetaxel. So, and that's the problem actually. So there was and second is actually all the patient we are trying to use either abiraterone or enzalutamide, but it's depend upon the case-to-case basis.
Dr. Deepak, if you have to use doublet, which patient do you use add docetaxel and which patient you add either AA or enzalutamide in your practice?
So for most of my patients, I use first line ADT with abiraterone acetate.
Abiraterone acetate, okay. And you don't use docetaxel even in highly symptomatic, chartered trial, high volume disease definition, you find both are equal?
Yes, sir.
You find both are equal. Dr. Amit, where do you use docetaxel and where do you use second generation androgen receptor blockades? If you have to use doublet in your patients.
So I think since the data is more or less equal, then we have to take the clinical call. So what I do in my practice, less than 60-year patient with the visceral disease, although the data says with a high Gleason score, so a Gleason score of 10 with some sort of neuroendocrine differentiation.
So we are not talking of neuroendocrine differentiation. We are talking of purely adenosine.
Even some adenocarcinoma may have, so pathologists can
3 to 4%. Yes, you remove those 4 to 5% of neuroendocrine. We are talking of adenosine.
But if the histopathology says that patient is having conventional adenoma with some sort of, then the possibility or the preference for using docetaxel will be slightly more.
Perfect. Point well taken.
Yeah,
Point well taken.
Gleason 10, that means a disease which is a less secretory patient and young fit patient. So we prefer, at least in younger group of the patient, we prefer docetaxel over abiraterone. And the other reason is that at this point of the time, patient may tolerate chemo better. If by chance after 3 or 4 years his general condition might not be fit for receiving the newer hormonal therapy. So I prefer using chemo early in the disease rather than keeping in the late.
Rather than shifting later. Perfect. I follow Dr. Deepak's practice because abiraterone acetate versus docetaxel, the European real world data had shown that A slightly benefits over docetaxel. When I have to use doublet, I have used abiraterone acetate even in the high volume disease, and patients have done quite well. This is what we follow, because NCCN says category 1 in both.
Amit sir, can I put a point?
Yes, Bharat.
Sir, this is what I exactly say. Sir, for all patients, irrespective of high volume, high burden, the hazard ratio in latitude and stampede for high burden was 0.62. And for docetaxel in charted is 0.8. So, sir, although we should not do a cross trial, what I feel is for all patients, irrespective of high burden, low burden, whatever you call, we should add a abiraterone. It is docetaxel where we should add on in a high volume synchronous disease, what I feel.
I think with the availability of the newer, the piece one and all that, things are become easier.
Easier, that is what I want.
We are coming to piece 1. So let's talk of the piece 1, and we have just 5 more minutes. So I will run through piece 1 and Arasense, and then we'll come to the panelists. What would they do? So piece 1 was a 4-arm study where they use radiotherapy alone and radiotherapy with abiraterone. So it was basically to sense the triplet. You give ADT, you give abiraterone acetate, and you give docetaxel. That was what basically they wanted to see in these. RPFS, the primary endpoint, was presented in ASCO 2021, and ESMO 2021 OS data was presented. And as you can see, 81% of the patients were mainly bony disease without visceral disease. So this was the primary endpoint which was presented in ASCO 2021 and which was a highly statistically significant with hazard ratio of 0.5. With tumor burden, if you see, again, high volume versus low volume, both were primary endpoint was positive. and it did not cross the unity of line. That is what my reading says. But when you look at the overall survival in the low volume in triplet, it was crossing the line of unity, even though it was not statistically significant. Some people say that the data is immature as yet, but this was one cohort where low volume was not statistically significant, but RPFS was statistically significant in these patients. There was enough number of 46% of the patients had received the next generation hormone, and there was 74% and 84% patient after receiving triplet also received when they became CRPC. So question was that do we change our practice in RPFS or OS data? Piece 1 conclusion was that in high volume disease, they would change their to triplet. Let's look at ARASENS. ARASENS is darolutamide and Dr. Mittal presented in non-metastatic disease. This was also classical to see whether triplet is better than doublet. That was what the study. Instead of abiraterone, they used darolutamide. Again, the characteristics were almost similar to piece 1. The primary endpoint was overall survival in this study instead of RPFS, and they achieved primary endpoint and they reduced the risk of death by 32.5%. That was what it was. The subsequent life-prolonging therapies were again used in majority of the patient. So you cannot say that overall survival was purely because of this. Again, de novo metastatic disease fared better compared to recurrent metastatic disease, and Bharat had shown these graphs quite beautifully well. And in fact, he had much more detail about this. The line of unity was crossing in recurrent metastatic disease. So the author said that de novo metastatic disease fared better compared to recurrent metastatic disease. This was just that time to CRPC and time to pain progression both were high. Adverse events were manageable. So let's start with Amit. Amit, we have 3 more minutes left. I want your conclusion. Where would you use triplet therapy today in 2022? Where would you not use triplet therapy in 2020?
So I think one thing is clear that in a high volume disease, the patient is fit, triplet should become the standard of care with the availability of data. Whether abiraterone versus darolutamide, that will be another discussion. But in a fit patient, a young patient, definitely that in a high volume disease, I will prefer. In a low volume disease, the single therapy with either Abi or Enja or a Dora can be
So in a low volume disease, RPFS was highly statistically significant in both the studies. Amit, a young patient with low volume, you would still wait for OS data. You would not use the triplet.
Yes, I will wait for the data to mature. In a low volume, still with that.
Deepak, your call.
For high volume disease, I will use triplet.
High volume disease, you will use triplet, and in low volume disease, you will not use triplet. Even in the young patient, even in young symptomatic patients. Okay. Then Dr. Mohapatra.
In high volume disease, it's yes. Actually, in low volume disease, maybe darolutamide if it comes with combination with chemotherapy, because that will be less toxic actually. Those patients maybe I'll be using.
Okay, Dr. Mohapatra, looks like you have seen a lot of side effects of abiraterone acetate.
It's not like that, but I think when it's a long-term therapy, when it is actually, if you see the trials also, the trials, the side effect it's a bit more if you combine with abiraterone with docetaxel than darolutamide with docetaxel.
Right. I will ask the last few one line from both our surgeons, Dr. Amitabh and Dr. Hemant. What do you take of this doublet and triplet tomorrow when you have HSPC patient in front of you? Dr. Amitabh first.
Okay. So we have started practicing triplet therapy at Rajiv Gandhi Cancer Center.
Okay.
So initially they are doing very well. So their side effect profile is almost same with the docetaxel as we were giving as a monotherapy, adjuvant therapy. So they are not having any additional side effect, and they are doing very well. But
Dr. Amitabh, since you have started practicing, let me ask a very practical question. Somebody who's on doublet therapy 6 महीना हो गया है, and now we have this piece 1 and ARASENS data. Patient comes to you. Would you offer to add triplet in this patient at this point of time?
Okay, so that is very practical question. So when this piece 1 trial came, this result came now. So the old guard, old practitioners, they had some reservation about the results. So instead giving triplet therapy, they had like logic behind giving just consecutive therapies, like just after stopping 6 cycles of docetaxel, rather waiting for the this window period or this drug holiday, you can add on abiraterone immediately after stopping the docetaxel. So I think these are the practical modifications, and they will be in the practice. You can't change them.
You can't change them. Correct.
You can't change them.
I have kept it as that 6 months window period. If it is more than 7 to 8 months, I wait for subsequent. If it is less than 6 months, I have started offering them triplet therapy. There is no right or wrong answer here. Dr. Hemant, any word as a surgeon about doublet and triplet?
So that, sir, I think only thing is now triplet therapy, if the patient is high burden disease and he is very severely symptomatic, I will go with triplet therapy. Only thing was earlier abiraterone, we also have some reservation about the side effect. So with the darolutamide and docetaxel, it is very easy to give triplet therapy. So I think that is what we will also counsel the patient.
We will also counsel. So I think we all have reached the consensus that this is today's. I have taken out NCCN version 4 2022. It does not mention about the triplet right now in M1, and we all would like to see that they add one more in a fit high volume disease. You can use the triplet therapy, and that is a consensus which this panel has reached, which I completely agree with that. With that, thank you all the panelists. I have overshot by 3 minutes. I am sorry for that. Over to organizers.
Thank you, sir.
Thank you.
Dr. Tejinder and Dr. Somani, both of you are muted.
Okay, sir, it was very nice. Your presentation and interaction with the panelists. So many questions must have been arisen in the minds of the listeners. So any questions from the audience is welcome now.
I have made a comment in the chat box.
Dr. Amis, please.
Many younger patients come with unusual presentations and visceral disease at presentation. Maybe right choice for triplet. Absolutely right, Dr. Somani. There is no doubt about that. We have now 2 studies. I think triplet is, according to me, is now a way of life for high volume at least. I would definitely offer for low volume also. We have overall survival data in 3 trials now, in PEACE, in ARASENS, which was a primary endpoint, and ENZAMET in the long-term 72 months follow-up data. I don't think that any of these patients with visceral disease at presentation, we should offer them triplet, unless until you have some difference of opinion, Dr. Somani.
So for my patient who is otherwise fit, can't afford Enja or something more, can I give the triplet with the dosi and the bicalutamide?
That bicalutamide no longer considered as one of the arms. ADT versus ADT plus bicalutamide, sir, the trial results. I don't need to tell you, you know more than us. I think abiraterone acetate, if anybody who can afford 6 to 8 cycles of docetaxel can afford abiraterone acetate also, sir.
Dr. Amis, any take on low dose abiraterone, like 500 mg with food or
I think Dr. Sahu had done a very good job in one of the panels, and we have now enough data that low dose almost works equally as high dose, what is recommended. So if the patient cannot afford, or if you feel that the patient has some side effects, which, abiraterone acetate can exacerbate, you can start with the low dose. Absolutely okay, sir.
So I would like to add one point also.
Yes, Dr. Amitabh.
So at our institute, so we have retrospectively analyzed our data. So although there were like many crossovers between 1 gram to 250 milligram. So after analysis, we found that almost 30 patient and 35 patient in each arm. and the radiological progression free and PSA progression is almost same, because I can't like analyze overall survival data, because I need to see like all these patients for like 4 more years or
Correct.
2-3 more years. But the radiological progression free and PSA progression free survival is almost same, between 1 gram and 250 milligram.
Correct, correct, correct.
So one more practical question: which docetaxel schedule protocol you like to follow, 2 weekly or 3 weekly in the metastatic setting? Usually we give.
The
So,
3 weekly is what every trial have seen. 2 weekly in neuroendocrine tumor. Some people have said if you add carboplatin with docetaxel or cabazitaxel plus carboplatin, you can try to give 2 weekly in a neuroendocrine high component if you don't want to use cisplatin tococyte. That is where it has been recommended. But apart from that, full dose of docetaxel 2 weekly becomes too much. Weekly, none of us practices anymore after the randomized control trial. So I use 3 weekly, and all the trials have also used 3.
Thanks a lot, Dr. Amit.
There is
Thank you so
also
much.
one new drug coming up apart from this inxalutamide. There is a new Chinese drug which has again in this ESCO because of time against bicalutamide, and it is statistically significant. So one more drug will be added provided FDA approves it now.
And provided Chinese people reach America.
Chinese people, sir, that is one. That was a Chinese new drug. This has been this year.
Okay.
So, thanks, Dr.
More
Amit.
crowd in this.
And Dr. Bharat also.
Thank you so much.
It was
Thank
a
you,
very
Bharat.
good, and it was a good interaction. So we now move on to the next topic. The next topic is practice changing abstract in ESCO 2022 in gynae cancers. And the speaker will be Dr. Prashant Narayan, consultant medical oncologist at Site Care Hospital, Bangalore. Dr. Prashant, most welcome, please.
Is Dr. Prasad here? Can someone call him personally if he's here? Arun and his team can.
But
Yeah.
I had, sir, Naresh sir, I was there. I am there. I had actually recorded the session. So if that is not there, then I have to try to present it because there is some internet issue I am facing actually.
Okay, okay, Dr.
I had sent the recorded session. I can try to present it, but if the other one is there, that is better actually.
Arun, who is taking care? Who is there from the organizing team?
Hello, sir. Just give us a second. We'll play the video.
So, Amish, that's true. Prasad is already too famous. He must be presenting himself at 2-3 webinars at a time.
Hello, technical team.
So we should start categorizing the presenters or the faculties from A, B, C, and D. So the people like Amish Vora, Bharat Vaswani,
Z, sir,
Prasad,
people like me, Z mein aayenge.
they should be in the A category. Their viewership and their honorarium should be like that only.
Good evening. At the outset, I thank the organizers for this opportunity. So my job in the next 15 minutes is to discuss about the updates in gynecological malignancies from ASCO. I have included some abstracts from the other conferences this year as well. So we'll start with endometrial cancer. So the Cancer Genome Atlas has given a molecular classification for endometrial cancer as well. And I think in given time, the only thing which we are looking at is the DMMR status, but definitely the others are coming. And I will show you some abstracts which tell us what is in future for us in endometrial cancer. So this is the keynote 158 update about we all know about this pembrolizumab data. which was the tumor agnostic approval for pembrolizumab, which came from this trial. And the update happened, which said there was a response rate of close to 48% overall response rate. This was the first FDA approval in 2017. And this has led to an ongoing trial. We don't have any data on that now, but which is comparing with the current standard of care of carboplatin and paclitaxel with pembro or placebo. Similarly, this is the updated response rates. I already said it is 48% in this. The other blockbuster drug at least in WhatsApp has been dostarlimab. And this is the data from the phase 1 in endometrial cancer in DMMR status patients with a similar response rate as the pembro data. The drug got an approval in tumor agnostic approval it got, and there is an ongoing phase 3 Ruby trial. So we will be waiting for these two trial data, which may change our first line management. And this is the response which was seen in the Garnet study across the cohorts. Now, what is there in second line option? We saw this trial. I thought I will present this data as well. This is a second line non-chemotherapy option in proficient MMR group of patients, published in NEJM this year. This is lenvatinib plus pembrolizumab as a second line option in proficient MMR. It was better than giving second line chemotherapy. Another important data to look at actually. So the fourth trial, which in endometrial cancer, which I thought I will discuss, will be about the selinexor trial. Now, this is how long we should give maintenance therapy and how frequently we should give in patients. When we were doing DM in medical oncology, I will not say which year it was. We did not had to read too much about endometrial cancer. Now we are talking about endometrial cancer getting into a maintenance therapy, that too weekly with selinexor 80 milligram IV. I don't know how many patients would want to be on a maintenance therapy like this, but definitely the study was showed favorable results in the patients who got maintenance therapy. We don't know how much this will change practice. So when you take the specific subset versus placebo, there was some improvement in the median PFS in the endometrioid carcinoma, 9.2 versus 3.2, small study, but definitely thought-provoking one. And in the P53 wild type, it was 13.7 versus 3.7. So definitely something is there, which will be, some studies will definitely look at this group of patients in endometrial cancer for maintenance therapy. So that is about endometrial cancer. We will go to ovarian cancer, which I think will have more data than endometrial cancer. And I think I have consumed 4 minutes of my allotted time. So we all know about the role of BRCA testing, HRD testing. So, and we have this confusion of what to test actually, the germline, the somatic, or the HRD or the HRR. So this was a study which the goal of the study from academic centers to identify new, reliable and feasible academic HRD tests. We all know the myriad test which is available and the problems which was there in the beginning. So this study, the LUN HRD test, compared well with the myriad my choice test in terms of the HRD positive group, HRD plus BRCA positive, or the HRD only positive group, or the HRD negative group. So something to look forward to about a new test. We hope that the test will be available for us and it will be less expensive as well. So there are so many paradigm shifts happening in ovarian cancer, the bevacizumab era, the PARP inhibitor era, and the PARP inhibitor beyond BRCA mutation era. And now we should think about what after PARP. So this time the discussion was about the maintenance therapy regardless of the PARP status. So this is the PRIME study as a follow-up of the PRIMA study, similar group, but stage 3 patients also included in this, niraparib versus placebo with for 36 months, and definitely a winner actually in terms of the primary endpoint of PFS, regardless of the BRCA status. We know that the majority of the benefit is brought by the HRD positive patients, but still, if you take the primary endpoint of the study, it's a positive study, needs to be discussed. Then we also have the other PARP inhibitor, rucaparib. This is a part of one trial, the Athena study, which had a combo group with nivolumab. We can only hope that for the sake of the costing, I think if this comes positive, we will be looking at giving nivolumab plus rucaparib as a maintenance therapy. But as of now, we are safe. We have the rucaparib single agent data, which is available, which is again positive and similar to the other data. So we don't know whether we should test the HRD positive HRD group now, because if all the patients will get benefit from maintenance, we should think about that. This can be a topic in the panel discussion. Then what about olaparib? So olaparib, we know about the BRCA mutation group. This study looked at the tumor BRCA as well, and just proved that what we know about the germline BRCA benefit stands good in the tumor BRCA as well. We know this, that it would have been similar, and it is similar in the HRD group as well. Now, this is the conclusion from the Orzora study. Nothing much to say about that. Then what is the emerging data in relapsed ovarian cancer? What after PARP inhibitor? So one of the recent data was in introducing antibody drug conjugates in ovarian cancer. This is the ADC against FR alpha group. So mirvetuximab soravtansine is the drug's name, complicated drug name, but this is the initial study which has led to the phase 3 study of giving this drug in 80% of the patients had unknown BRCA. All of them had received bevacizumab, 50% had received PARP, impressive results of 34% response rate. Even 5% had a CR rate in this group, heavily pre-treated groups actually. So interesting data to look at post-PARP inhibitor exposure and post-bevacizumab. And this has led to the to a randomized trial of this drug alone or investigator's choice chemotherapy. We will wait for the results of this drug. Another antibody drug conjugate against NaPi2b targeted as a target here. Similar group of patients, the drug's name is upifitamab rilsodotin, and similar results actually. So something to look forward to more than the PARP and the bevacizumab in ovarian cancer. And these are the ongoing studies with the same drug actually. And another study was the relacorilant plus nab-paclitaxel versus chemotherapy showing efficacy and safety has led to this Rosella phase 3 study, which compared physician's choice chemotherapy versus relacorilant with chemotherapy after 1 to 3 lines of prior therapy. So this is a glucocorticoid receptor glucocorticoid receptor modulator. So more and more studies with the different with different pathways being targeted in ovarian cancer. What about using a PARP inhibitor after a PARP inhibitor? This is an interesting study, I would say. The patient got PARP inhibitors in maintenance, they got a relapse, they got treated, and then they got into a second remission either with chemotherapy alone or with a surgical treatment as well. And they got olaparib again versus placebo. This was a positive study. So something to think about in our practice. We are seeing our patients who come back with disease after PARP inhibitors, whether we can re-challenge them, something to think about. Then two other studies also. One is the adavosertib plus olaparib in PARP inhibitor resistant group. So this is to overcome the resistance, just like we use CDK4/6 with hormone therapy, using adavosertib with olaparib or alone. This study has shown some responses in this group. We have to look for the long-term, the large data, but interesting study, another one. Similar study design with alpelisib, drug which is known to us, with olaparib in ovarian and breast cancer. Some responses we are seeing in this. Adverse events, this is too early to comment on this, but definitely some pathways being used in post PARP inhibitor and bevacizumab in ovarian cancer. The NGOT OV61 study is again alpelisib with olaparib. So take home messages, many advances made in ovarian cancer, new therapeutic opportunities, combination strategies including immunotherapy being tested, re-challenging PARP inhibitors was a specific thing of interest actually. And antibody drug conjugates, again, like in other cancers, like in breast cancer, this is something more promising in ovarian cancers as well. So let us move to the cervical cancer. the last part of the presentation. I think we have another 3 minutes. So this is the present summary of available treatment options. We see that in metastatic disease, we have moved from chemotherapy to chemotherapy plus BEV to chemotherapy plus BEV plus pembrolizumab, and now we have many other newer drugs which are described as second line options. So NCCN recommends that we do PD-L1, MMR, NTRK, and TMB. We don't do all this for all patients, but we do certain tests nowadays with the available data. The keynote study was the landmark paper, which actually the part of the same basket trial, the monotherapy. So the advanced cervical cancer update also came, the patients who had cervical cancer, and there was a improved efficacy. You can see the response rate overall was 14.3, and if it was PD-L1 positive, it was 17.1, and in negative, there was no response. So PD-L1 is a good marker to choose pembrolizumab in cervical cancer. I don't think we should talk too much about PFS and OS in single-arm studies. The other study, again, dostarlimab study, which we discussed before, is data in cervical cancer as well. And the keynote 826 is the study which looked at pembro chemo bevacizumab versus placebo chemo bevacizumab, led to the FDA approval of pembrolizumab. So the updated data, there is improvement in the patients in the intent to treat group as well as in the patients who were PD-L1 CPS more than 1 or more than 10. And PD-L1 seems to be a marker which helps to predict the response to pembrolizumab in cervical cancer. So if you take the subgroups also, the PD-L1 score was one which predicted the benefit, actually, if you can see from the forest plot. So safety overview, there is nothing much to say other than the usual immunotherapy related AEs. Another drug, the last one which I will present is tisotumab vedotin, another antibody drug conjugate. So this study, the INNOVA study, single agent tisotumab vedotin, second line treatment. Patients have received a doublet chemotherapy with bevacizumab and showing some pretty impressive response rates of 24% with CR in 7% of the patients. I think that's all I have, and happy to take any questions. Once again, thanks for the opportunity.
Am I audible?
Yes, sir.
Yeah, thanks, Dr. Prasad Naran, for wonderful presentation and clear message about the new things. Any question, anything from the audience side? So we have now the two panel discussion lined up, and more or less we are on the time. That's a good thing. So I thank once again to all the previous speakers, and our panel discussion is, the first is on the advanced cervical cancer. We have with us Dr. Sachin Khurana, Assistant Professor, Department of Medical Oncology from the AIMS, New Delhi, as the panelist. Dr. Sachin Khurana, please. And
Thank you,
I
sir.
will also be inviting the esteemed panelist, Dr. Jacob George, Consultant Medical Oncology from the Manipal Hospital, Goa, Dr. Shefali Sardana, Consultant Medical Oncologist from Max Super Specialty Hospital, New Delhi, and Dr. Ravi Jaiswal, again medical oncologist from the Ramakrishna Care Hospitals, Raipur, and Dr. Vinita Goyal, Consultant Director Radiation Oncology, Fortis Hospital, New Delhi. And I will also be joining in the panel discussion. So I hand over it to Dr. Sachin Khurana to moderate and to have the discussion regarding the advanced cervical cancer. What's new? What's the standard of care? Dr.
Thank you, sir. Thank you very much, sir. I'll try to share my screen here.
So we request you to please be in the time so that we can finish it well in the time.
Sure, sir.
Thank you, sir.
Is my screen visible?
Yeah, yes. To me,
Thank
it's
you.
visible.
Thank you, sir. So, thank you very much for this opportunity. Already, Dr. Naresh sir has introduced the panelists, and I'll straight away go to my my discussion. So, so I'll start with a small case scenario, and it's just a hypothetical scenario. Maybe a 47-year-old female presented with vaginal bleeding. On evaluation, was found to have a cervical mass Biopsy suggested of a squamous cell carcinoma, but on a staging CT scan, a paraortic lymph node was detected. So I think I would first maybe request Dr. Vinita ma'am to take up. Ma'am, how would you further investigate this patient?
So
How would you like to further?
Since it's a
Yes,
young
ma'am.
patient and she already has paraortic lymph nodes, which are quite sizable, as been shown on the CT scan, I would certainly like to do a PET CT scan for this patient.
Sure, ma'am. Ma'am, would you like to confirm paraortic lymph node on a biopsy, or would you be happy with the if there's an uptake on PET CT scan? And
I'll be quite satisfied if the paraortic lymph nodes are FDG avid, and may not make an attempt to prove them by biopsy or FMC.
Sure, ma'am. Thank you. Thank you very much, ma'am. Next would be plan of treatment. Paraortic lymph node is always considered a poor prognostic factor, and so I would request Dr. Ravi if he's there. How do you plan such patients? What treatment line do you offer them? Dr. Ravi, are you there? Maybe, ma'am, if you can take up, how do you plan and how do you manage paraortic lymph node?
In the new field of staging, we have to realize that paraortic lymph nodes are now considered as a part of staging, and now they are labeled as stage 3C. And the standard treatment for even for paraortic nodal positive carcinoma cervix still remains concurrent CTRT with cisplatinum as the radiation co-partner, followed by brachytherapy. However, if my patient has a poorly differentiated carcinoma and if the nodal metastasis is big and conglomerate, sometimes I do consider NACT, 2 to 3 cycles followed by response assessment and then CTRT. I admit here that there is no scientific evidence, clear evidence available to support the use of NACT in this approach.
Sure, ma'am. Thank you, ma'am. If I would, as you are an eminent radiation oncologist, I would just like to ask, how do you? I mean, you take extended field to cover paraortic lymph node, and how safe is the RT for those patients in which you use an extended field? What kind of toxicities you encounter?
So any patient who has paraortic lymph node positive disease would certainly merit extended field radiation covering the retroperitoneal lymph nodes. We also push an extra dose to these gross lymph nodes, and it is quite safe to do that using techniques like IMRT and IGRT. But certainly it is not possible to treat them well without these advanced radiation techniques. And with the use of these advanced radiation techniques, the toxicities, I mean, if you are concerned about late high-grade toxicities, they are less than 5% grade 3 and grade 4 enteritis, which is known to occur because of this extended field radiation.
Thank you, ma'am. I think
it's a quite safe approach.
Yes, ma'am. Thank you very much, ma'am. I think that was the point which I just wanted to discuss. I think these patients need extended field RT, of course, and with IMRT and IGRT, I think the chances of toxicities are reduced. So that is a way we can manage these difficult patients who actually have a poor outcome. Ma'am, you just touched the idea of giving systemic therapy. So I would request Dr. Shefali to give her views. Do you use NACT in your clinical practice?
So generally, I would agree with Dr. Vinita that we practice concurrent chemoradiation with extended field RT to cover the paraortic nodes. However, if the nodal burden is much, there are multiple paraortic big nodes. So in that case, we start with chemotherapy, see how the response is, and we may add with concurrent CTRT in a later stages. Or I would agree on that also, that in some patients after doing concurrent chemoradiation, we individualize according to nodal burden and give some cycles of adjuvant chemo. Many trials have tried to look into this answer if we can give adjuvant chemotherapy to such patients. There is no level 1 evidence. However, but every trial has concluded in the end that it should be individualized. So in that scenario, not a routine practice to give any adjuvant chemo after CTRT in such patients, but of course the nodal burden would matter.
Sure, ma'am. Thank you. I would request Dr. Jacob if he's here. Dr. Jacob, are you there?
Yes,
so in your practice, which patients you offer NACT in a locally advanced cervical cancer? Are there any patients who offer NACT, or you are not a fan of systemic chemotherapy in cervical cancer and you just go ahead with CT-RT and just observe?
Almost all RT, except for maybe when you can't do RT upfront, like bladder involvement or something like that. Otherwise, we always give radiation with cisplatin.
Okay, sir. Thank you, sir. So I think Dr. Shefali just touched on the point that systemic chemotherapy is still a bit controversial. Many trials have tried to address that. And I think the most recent trial was the Outback trial, which failed to show a benefit of using adjuvant chemotherapy of locally advanced cervical cancer stage 1B3 to 4A. They gave 4 cycles of chemotherapy. There were higher toxicities, but no OS or PFS benefit. Naresh, sir, your take on this trial? Do you agree with the findings, or you believe that systemic chemotherapy still has some say in locally advanced cervical cancer? Naresh, sir.
So I don't practice it. I don't, and I do agree that it doesn't have the role anything at present. Even if the residual disease is there, either you try to do the extensive surgery, exentration or so, or take it as the refractory or metastatic disease and then treat it. Classically, adjuvant treatment with the platinum doublet like paclitaxel, I mean, I don't believe that there is any benefit we are going to get it. But I foresee, I just wanted to make the comment also, that very soon these IO immune checkpoint inhibitors with chemotherapy or single agent, they may dent in the adjuvant setting also in this scenario, to make it as the 1 year or 2 years of the standard of care, which we see in many situations.
Yeah, so I think there was a trial ongoing with durvalumab with CT-RT. I think if I'm not wrong, I think it wasn't positive, but I think still we need to see the full paper. But definitely IOs IOs have a promise, and they may change the standard of care. So I think the point is clear here that systemic chemotherapy is still a bit controversial. Maybe need some more data, and maybe it's only the CT-RT which should be the standard of care. But here I would like to ask actually all the panelists, because even with CT-RT, even with radical CT-RT using cisplatin, we have distant relapses. So one point Dr. Naresh has already pointed out, that maybe IO will come, and that would be the way forward for reducing distant relapse. What else do you think would be there? Maybe Dr. Shefali, if you can take up. What's the way forward? It's an unmet need, I would say.
Yeah, so I mean, as of now, we don't have anything as a maintenance regimen after treatment with CT-RT in case of CA cervix. However, when we see the Outback trial also, probably they have not categorically included that volume of patients who had extensive nodal burden. That is what they conclude in the abstract also. So probably it's the individualization of the treatment, and like Somani sir also mentioned that time may come when we have IO plus chemo as a adjuvant setting in such kind of patient to maintain the response. But I don't think as of now we have any evidence or what we practice to consolidate the response after CT-RT to prevent distant relapses.
Absolutely. I think one point here which I feel is important is that Outback trial included patients who were stage 1B3 to 4A, up to 4A. And I think these different stages have different prognosis and different outcomes. And as the stage advances, we all know that the outcome becomes poor. So maybe if we choose patients for systemic chemotherapy, maybe if we have a trial, which select patients who are more advanced, then maybe we have a positive outcome. Dr. Vinita, your take on Outback trial and role of systemic chemotherapy, ma'am.
So I completely agree with the point made by you, that because all stages starting from stage 1 to stage 3 were, probably included, and that is why the trial probably did not show a survival advantage. And if they were selecting they had selected higher stage disease, probably maybe the advantage would have been there. I also wanted to make another point that I'm inclined to add either NACT or adjuvant chemotherapy, especially when it is adenocarcinoma cervix. I'm more inclined. And I'll give you another scenario. Recently, I had this patient. She had poorly differentiated squamous cell carcinoma of cervix, very small primary with very, very large nodes. So something was not matching there. Usually, I would expect a stage 3 kind of a cancer with a bulky cervical mass to have those kind of nodes. So these are some unusual situations where I would consider NACT.
Okay, thank you, ma'am. Absolutely. I think that's another point that adenocarcinoma may have some more preponderance for systemic metastasis, and systemic chemotherapy may be an option for them.
There is one Chinese randomized trial which has shown a survival benefit, although a lot of people do not believe that Chinese trial and follow it in practice.
I have put a point in the chat box.
Yeah, sure, sir. So another, I think another large trial for NACT is also going interlace trial. So we are still awaiting the result. That's a trial being done in UK. They are looking at weekly NACT, weekly peclicarbo as NACT in cervix cancer. And Dr. Vinita, I just wanted to ask one thing. There are still reservations about NACT in cervical cancer, of use of NACT. Your take, why do you think NACT, some say that it compromises the overall outcome, giving NACT and not starting upfront RT. Your take on that, and then I'll come to
Now
Naresh.
we have a randomized trial in early stages where NACT did not show any advantage over concurrent CTRT. I'm talking about the trial which came from PMH about 2 years back.
So I largely agree with what Dr. Vinita Goyal just commented, and the response are not so great, but only when the rectum involvement or the RT becomes a difficult situation, bladder or rectum infiltration, or then maybe that situation we try to give it, but we see that most of the time we do fail. We don't give the much objective response or radiological response to make it a tumor, which can be included in the preview of the radiation later on. With the available doublet, I think the response is not so great. Until immune checkpoint inhibitors in combination with the short chemo shows the great response, which is coming in the head and neck cancer. Neoadjuvant chemo plus IO or short course of the IO with the major pathological response more than 50%. If something equivalent is being demonstrated in the cervix cancer, I don't think neoadjuvant is going to have the dent in the cervix cancer.
Sure, sir. So
One
that's
point
that's a
more,
very
Dr. Sachin, if you allow.
yeah,
So,
please,
if I
ma'am.
remember correctly, Outback was classified according to FIGO 2008 staging when there was no 3C group of the paraortic lymph node. So that is the one group, because when we analyzed in our tumor board, we realized that this was the subgroup which was not categorically included in that trial to see for the benefit of adjuvant chemotherapy. That is why in patients with high nodal burden with paraortic, I think we should await for any other more trial or result which will conclude that whether we can maintain or consolidate that response with CTRT.
Dr.
Correct me
Sachin,
if I am wrong.
we are little bit late, and we have the one more panel discussion. So,
Sir,
I request you to
I'll
be
quickly
kind
wind
enough.
up. Yeah, sure, sir. So that's another point made by Dr. Shefali, and we'll keep that in mind. Of course, nodal burden. So I'll just move on to my next thing. So the patient relapses after 1 year with lung mets. What will be the favored first-line therapy in such patient, Dr. Shefali?
Yeah, so now we have IO plus chemo trial available. So I think my choice would be pembrolizumab chemo plus bev, if available, or otherwise chemo plus bev if patient is not able to afford pembro. So that would be my choice for to go further on chemotherapy.
Okay, Naresh sir.
So
your first line.
For practical purpose, I divide based on the PDL1 positive, chemo plus pembro. If negative, then maybe chemo plus beva, if there is no contraindication for the bevacizumab.
Okay, thank you, sir. Dr. Vinita, how do you select your patients for bevacizumab? It has some ready toxicities known, like fistula and everything. So which patients you will not give bev, and which patients you will offer bev?
I'm very glad that you've asked this question. Whenever bevacizumab is added in this setting, I'm a little worried, especially when we've given extended field radiation and a lot more dose has gone to the small bowel. We have to remember that although the risk might not be very high, but the risk is still about 10% risk of bowel perforation, fistulas, etc. This risk would be certainly higher in case the bowel dose was high, or in any case, if patient has received any kind of stereotactic body radiation therapy, meaning high dose of radiation therapy, then the risk is certainly higher. So far, I have seen one such patient with very bad perforation and fistula.
Yes, ma'am. Absolutely. I think that's very important point. While selecting patients for bevacizumab, we need to know if previous RT was given. If we need to know whether there is central disease or not, and we need to know about the dreaded toxicities of bevacizumab also. So I'll quickly wind up. We have discussed about checkpoint inhibitors, and Dr. Naresh has made the point that it may be practice changing in the future. This is the trial for pembrolizumab, and BEV was also allowed. Dr. Prasad Narayan has already touched this trial, so I'll not go into details. And
most of the patient receive chemoradiation actually.
Yeah, that's
receiving
the thing.
Yeah.
So that's the problem, ma'am.
I think discussion in the MDT is what can help.
That is actually very important, and I personally I'm always very confused when I'm selecting patients for BEV, because the toxicities are if the patient develops this fistula, vesicovaginal or RVF, they have a very poor quality of life, and that what worries me. So I'll just move on to this new drug. Dr. Shefali, your take on this drug? Now it has shown some benefit with combination also. I think obviously it's not available in India, but yeah, of course. But what do you think? Will it become the standard of care, or will you be using it?
I mean, yeah. So this trial was actually done in metastatic recurrent setting when the patient did not receive any kind of chemotherapy or any kind of the systemic therapy before. So this was the same setting as patient received pembro plus chemo. So when we see the results, though of course it's a cross trial comparison, should not be done. I think pembro is well tolerable. The results were more better. Small number of patients in tocilizumab group. So I mean, if I have to choose either of them, I would go for the pembro plus chemo or plus minus bev arm rather than this. But of course, it's all theoretical till we have hands-on experience. We can't decide for it actually.
Of course, ma'am. Naresh sir, your take on tisotumab?
So it's not going to be available in near future.
Yeah,
I'm not so optimistic for our
know.
patient and for discussion. And I believe that the combi of chemo plus pembro, and if second line, then maybe the topotecan plus beva, if there is no contraindication for beva. Beva I would like to give in the first line or second line whenever I get the opportunity and there is no contraindication. I'm more used to the drugs like topotecan, easily available and doable.
Yeah, sir. Topotecan, what I have encountered is marrow toxicity and poor tolerance to topotecan. That is something, and these all patients are irradiated. The marrow is irradiated. So sometimes I find it really difficult to handle topotecan in this patient. But otherwise,
I give standard of care as I give it 4 days. That's my standard of care.
Yeah. So just now last point, Jacob sir, your take on BEV, use of BEV, and your take on tisotumab. I missed you on the discussion while I was doing for BEV. Jacob sir.
BEV, I am kind of concerned when you have again, like Madam said, more radiation to the bowel, and particularly when you have pelvic disease. The pelvic disease is not under control. A lot of times they come with fistula.
Yes, sir.
So tisotumab again.
Theoretical, sir.
yeah. I mean, for us, I'm not really sure there's a point in discussing at this point of time.
Yeah, of course, sir. I mean, of course, so it is coming up. It's just theoretical as of now, and let's see. So I think we are running out of time, and I will conclude my discussion here. And if there are any questions or any points to be made, you're all welcome, please, sir.
Thank you, Dr. Sachin Khurana and all the panelists for this important thing and making the things clear, the clear message. And in the short of the time, we would be going to the next and the last session for the 2 days. We have with us the Dr. Amita Maheshwari, Professor and Head Department of Gynec Oncology at Tata Memorial Hospital, Mumbai. She will be moderating today's session on the management of the uterine sarcoma. And I would like to invite all the panelists with us today, Dr. Rupinder Sekhar, Senior Consultant and Chief of Gynec Oncology at the Rajiv Gandhi Cancer Institute, Dr. Sada Sivadu from the NIMS Hyderabad, and Dr. Abhishek Singh, Dr. Tejinder Singh, Dr. J.B. Sharma, and Dr. Amol Dongre. Dr. Dongre is from Alexis Multi-Specialty Hospital, Nagpur. Dr. J.B. Sharma is well known to all of us. He is the organizing person, as well as Dr. Tejinder Singh. I think Dr. Tejinder is not available. And Dr. Abhishek is from the Chandan Cancer Hospital, Lucknow. So over to you, ma'am, Dr. Amita, madam.
Yeah, hi, very good evening, and thank you, Dr. Naresh and organizers for the opportunity. And I would also like to invite Dr. Santosh Menon. He's a special invitee. He's a gynec pathologist at Tata Memorial Hospital. So, Santosh, welcome.
Thank you so much. Thank you.
So, in the interest of time, let's directly go to a clinical case. A young lady who was undergoing investigation for primary infertility found to have a 10 centimeter uterine leiomyoma and underwent laparoscopic myomectomy by her gynecologist. Power morcellator was used. So for non-surgical colleagues, just to give you a little feel, what is this morcellation? This is not from the same patient, but just to tell you what happens during morcellation of any tumor. So tumor is removed strip by strip. You can see there is gross spillage and contamination of the cavity, which is inevitable unless it's done in an endo bag, but which is, often doesn't happen. So this was the case in this patient, because video is not of this patient. So post-op recovery was all right, but unfortunately her histopath came as malignant mesenchymal tumor, query leiomyosarcoma. So at this point, this patient was referred to you, Dr. Rupinder, and what will be your plan for her?
So good evening, everyone, and organizers, thank you for the opportunity. So we do sometimes, unfortunately, get such cases. So first thing what one would want to do is a slide and block review to actually confirm that, yes, are we looking at an LMS and what is the type? Then,
right. So I think you made a very valid point that histology review by an expert pathology is absolutely essential, and sarcomas are challenging not only for clinicians, but they are equally challenging for pathologists, and that's why even NCCN guidelines recommend that expert gynec pathology should review these cases. So here we have Santosh Menon, gynec pathology. Santosh, would you like to just brief us on uterine sarcomas in brief? Yeah. You are not audible. I think you are muted, Santosh. You need to unmute.
Yeah, am I audible now?
Yeah.
So as you have put up, this is the 2020 classification, and like Rupinder madam and you have alluded already, these are difficult tumors, and the list is ever growing now of the sarcomas. So like most common are the leiomyosarcomas, and then you have the all endometrial sarcomas, which are again of several varieties like low grade and high grade. Again, several molecular different types. And if you these diagnoses are basically based on pathology. If you look at leiomyosarcoma, it's basically based on pathology with features of mitosis, atypia, and necrosis. So those are the important features. Many a times pathologists make mistake in counting the mitosis, and that's why they put them in different categories. So it's very, very important that basic histology is taken into consideration based on atypia, cell necrosis, and mitosis. So those are the essential points in diagnosing leiomyosarcomas as far as coming to different other types of sarcomas like endometrial stromal sarcomas. There are a variety of them, and as you see this list here, there is low-grade endometrial sarcomas, and high grades are now divided into BCOR and YWHA translocated. And thankfully, we have started doing YWHA at our center, and so we are able to diagnose these high-grade sarcomas. And I'm sure in coming years they will have different kind of therapies based on these molecular markers.
Okay, I have two quick questions for you. So you did mention about mitotic count, but there's little controversy. Someone would say that leiomyosarcoma by definition all are high grade. Is that true?
By in uterine there are no low grade leiomyosarcomas. We don't call. So the confusion here is with the stump, which stromal or smooth muscle tumor of uncertain managing potential, which may have a borderline mitosis vague necrosis which is indeterminate, and those people, some of those people, some of those tumors are labeled as low-grade leiomyosarcomas, or they behave like low-grade leiomyosarcomas when they are seen on follow. So that's a term, but in uterus we have only high-grade sarcomas, either epithelioid or myxoid or the classical variant.
Typical IHC markers we do in cases of sarcomas.
Yeah, so generally the DDs are leiomyosarcomas and endometrial sarcomas. So the common markers are the smooth muscle actin, desmin, CD10, and now because we have high-grade ESS, which are positive for cyclin D1, which is like a screening marker which we use for high-grade sarcomas. And then we have BCOR IHC, which is available, and we try to delineate on these on IHCs based on a combination as per the WHO table of IHCs.
And we often request for ERPR.
Yes,
So
ERPR.
that may
That's
not
the
be
only
for
thing,
your
because most of them are
diagnosis, but
metastatic
for
at
us,
presentation.
yes, it has therapeutic implications. So just quickly, what is the significance of these, high-grade dividing in based on molecular profiling?
So under the microscope, many of these sarcomas may look similar with myxoid and all. So currently, there are no therapeutic implications of diagnosing these, except for placing them in a high-grade category. So especially the YWHA mutant one, you may have low-grade arrays in them, actually. So if there is a small, limited amount of tissue, we may end up calling them low-grade. And that's when we want to do cyclin D1 and the molecular markers to actually label them as high-grade.
Okay, so they have more of diagnostic and prognostic value rather therapeutic at this point. Okay,
Can I just ask one small thing?
Yes, sure.
Santosh, at places we read this terminology, geographical necrosis. What does that mean?
So in leiomyosarcomas, we use the word coagulative tumor necrosis. So it's called CTN, coagulative tumor necrosis, or some people call it geographic necrosis. This is true tumor necrosis. So it basically means that there is a imbalance between the tumor growth and the vascularity of the tumor. And that's what we may call mean by aggressive tumor. And that's why they undergo necrosis. So that's a feature to tell that they are aggressive. And that's why we try to pick up the coagulative tumor necrosis.
Thank you, Santosh, and I think you set stage right for further discussion. So coming back to our patient, the diagnosis of leiomyosarcoma was confirmed, and it was ER 10%, PR 5%, so essentially ER, PR negative tumor. Dr. Rupender, I come back to you. She's a case of primary infertility, she's skin, but you think any role of uterus preservation in sarcomas in general?
I don't think so. No matter how much you feel for her infertility, there's absolutely no role for uterine preservation at all.
Right, I agree with you, because there are very rare cases of low-grade ESS where some nodule has been excised, but I think I absolutely agree with you. There is essentially no role of uterus preservation. But what about ovaries? So are there cases where we may consider ovarian preservation?
See, if we are able to counsel the patient, properly and explain to them that carrying the ovary is definitely a high risk for her, and maybe she can take a chance. Sorry, if she's very young, we preserve the ovary and tell her to have a family, or howsoever she does that with ART, and subsequently definitely take it out. But all these are off the cuff counseling. We wouldn't really want to preserve the ovary, especially if we have done an ER/PR and it is ER positive. So we know it is a high estrogen setting. So in a high estrogen setting, the role of ovarian preservation is definitely doubtful and not the standard of care.
Right. So any other panelists, anyone wants to make comment here?
Yes, I think I am Dr. Sadashiv, ma'am. Yeah. So I think this patient is too young to do something like bilateral salving ovarectomy. Too young, I think. It's very difficult to something sustain this ovarian suppression for again next 15 to 20 years. I think
she survives.
yeah, but problem is. So problem is, of course, madam. The problem here is, I think we have to balance the both. What madam said, I think yes, I think the ovarian, but in this leiomyosarcomas, the bilateral salving ovarectomy did not improve any survival at any point of time. So because a doubtful role is there, but especially the perimenopausal, definitely we can consider bilateral salving ovarectomy.
Right. So
but
in low grade,
too young, I think. Yeah.
So
Yes, ma'am. Go
low
ahead, please.
grade ESS, which is hormone dependent general counseling, it is to remove ovaries. The studies have shown if you don't remove ovaries, there is increased risk of relapse, although OS is not inferior because most recurrences are salvageable. But in LMS, in early stages, ovarian preservation is possible after counseling the patient. The next question is lymphadenectomy, and all these I am asking because even medical oncologists, they may feel the surgery has been incomplete and they may send back to surgeons. So let's have things clear whether all these structures need to come out or not if after hysterectomy. Okay, so lymphadenectomy, you think we should be doing for all, or what's your take, Dr. Rupen?
There's no role of lymphadenectomy in a patient with the leiomyosarcoma. Absolutely not. The incidence of lymph node metastasis is very, very low. In fact, there was a Chinese trial, again Chinese, where out of some 4,000 patients, which it was a retrospective study actually, not a trial really, where they found that only 4 patients had positive lymph nodes. So there's really no role of doing a lymphadenectomy.
Unless they're enlarged. Yeah, unless they're enlarged or clinically or immunologically, then only you can. Otherwise, there is no.
Are not enlarged.
In general, the sarcomas are hematogenous, right?
Hematogenous, yes.
Slightly increased risk of nodal metastasis in ESS, but if nodes are not enlarged, as Dr. Rupinder says, lymphadenectomy is not recommended, and don't send patient to surgeon for lymphadenectomy. Okay, so our patient, after counseling, she underwent hysterectomy and bilateral salpingo-oophorectomy, and also there was a deposit around 2 millimeter in pouch of Douglas, which was excised. Interestingly, her uterus and ovaries and tube were all right, but only pouch of Douglas deposit showed leiomyosarcoma. So just a question now, what adjuvant? And before that, let's see the staging. It's slightly different than what we use for endometrial cancer. So many of us may not even remember this staging. Stage 1 is based on tumor size, but stage 2 is either adnexal involvement or other pelvic structure, and stage 3 is outside the pelvis. So this patient, I don't know now, she was early stage disease, but as a result of inadvertent surgery, there was some tumor which was in the pouch of Douglas, but I guess we will label as 2B disease because there was a tiny deposit in pouch of Douglas, which was outside the uterus. So let's discuss the role of adjuvant therapy, say in early stage in sarcomas. If it's a uterine confined disease, what do you think is the role of adjuvant therapy? Dr. Abhishek, Dr. Amol, and Dr. Sharma, anyone can. I can't see who all are there.
Well, ma'am, like as you said that there's a deposit in pouch of, I'm Dr. Amol, ma'am. Sorry. Yeah. So, there's an involvement of pouch of Douglas and it's a leiomyosarcoma. Definitely, we did a completion surgery. But I guess this lady warrants adjuvant chemotherapy. I would prefer to give her a combination chemotherapy.
Okay, we'll come to that. But suppose this was uterus confined disease, a 10 centimeter leiomyosarcoma, receptor negative high mitotic count. What is your policy? Do you give adjuvant treatment or observe them?
Ma'am, still, if it's a high mitotic activity, I would still give 5 cycles of adjuvant chemotherapy, considering the, high mitotic activity. Leiomyosarcoma, we all know almost, even in stage 1 and 2, the risk of relapse is almost 40 to 50%.
The question is, does chemotherapy prevent them? Dr. Sada, what will you do?
I think
so. Stage 1,
stage 1, stage 2. I think there is no role of adjuvant chemotherapy. So people, if they think something the high grade, they may spread beyond. But I think stage 1, stage 2, I don't consider for any adjuvant chemotherapy.
Dr. Sharma, if you're there, and Dr. Abhishek.
Ma'am, Abhishek, this side.
I agree. Yeah.
Hi, Dr. Abhishek. Yeah, Dr. Sharma.
Ma'am, in stage 1, definitely no role of adjuvant chemotherapy or any adjuvant therapy per se. I would observe the patient if it is stage 1. Stage 2 until 4, there are recommendations for adjuvant chemotherapy. In the stage 2, I would consider giving single agent doxorubicin in some patients where there are some high risk features like high mitotic index and other things. But in all patients, generalized, if I have to say, even in the stage 2 also, I would observe for some extent. But other stages 3, 4, definitely some adjuvant chemotherapy I would prefer to give.
Okay. Dr. Sharma?
Yeah, I agree with all the panelists that in stage 1, there is no role of adjuvant chemotherapy. The specimen has been removed intact. And for stage 2 also, there is a high chance of recurrence if there is incomplete resection or there is a residual disease, or for patient, particularly in our case where morcellation has been done. So in these cases, there is very high chance of relapse. So I think these are the few isolated selected patients where there is some benefit of adjuvant chemotherapy.
So unfortunately, adjuvant treatment doesn't work. This was a trial looking at the role of radiation therapy, and it failed to show any improvement either in OS or local recurrence in LMS compared to observation. And similarly, this is a single arm study which showed some benefit with adjuvant therapy. However, a randomized trial which was to plan to compare GEMS dosi followed by doxy, actually it failed to accrue adequate number of patients, and therefore it was stopped. So current guidelines suggest that there is in stage 1 observation only is recommended. However, there are certain prognostic factors which have been identified, which include age, tumor size, grade, cervical involvement, and mitotic count, and what we all have discussed. But these, based on these, they do tell about the prognosis of the patient, but I think they do not really help in deciding adjuvant therapy. But I agree with Amol that we have, as a surgeon, I have a very strong tendency to send all cases for chemotherapy, and our medical oncologists by and large do not agree to give chemotherapy in early stage disease because it's as per guidelines. Okay. So chemotherapy, now we have two opinions. Someone said single agent doxorubicin as first line, and you said combination chemotherapy. So how do we decide which one to give?
Well, ma'am, I said it's a combination chemotherapy. So obviously for high-grade leiomyosarcomas, I would prefer to use a combination one. In fact, not 3 drugs, but definitely 2 drugs. That is doxorubicin-based chemotherapy. I don't know about other panelists, but yeah, my choice would be a combination one.
So you will use doxy and IFOS, or what will be the
ma'am. Doxa and IFOS.
Okay. What about what's Dr. Sada, Dr. Sharma?
Yes, I think there's a problem here is whenever we, as a medical oncologist, whenever we see any sarcoma, we tend to give the ifosfamide and adriamycin. That's a problem of all the medical oncologists. Okay, it's like we tend to, because the both are very active agents. But coming to this uterine sarcoma, there's most of the trials or studies are either single agent doxorubicin or docetaxel and gemcitabine. So the problem here is again they're compared with the doxorubicin versus dosi and gem. But there is no something like a survival benefit for this or that. So based on the individual preferences and based on the patient's comorbid conditions, you can choose the regimen. That's all. So if the patient prefers only single one, there's nothing wrong in using the single agent doxorubicin also here.
Okay, so I think the thing is because of fewer number of cases, we really do not have any level 1 or I must say level 2 evidence also this way or that way. And most has been kind of extrapolated from soft tissue sarcoma. But do you think uterine LMS are somewhat different from other LMS, or do they behave similarly in terms of response to systemic therapy, including chemotherapy and targeted therapy?
Well, ma'am, they are not similar to the other sarcomas, and I am sure all the panelists must agree to this, because they are not that chemosensitive. And that's probably the reason, you treat them aggressively, and that's the reason of using combination one.
Yeah. So I think, and there are some reports suggesting that IFOS is for some reason is not very active agent, at least single agent in uterine LMS compared to other sarcomas. So that may be the reason why Dr. Sada and others said that maybe single agent, or of course a large randomized trial which compared combination versus single doxorubicin found no difference, and considering toxicity profile, I think most people prefer single agent. Any experience with one of these drugs which NCCN mentioned? So anti-RK gene fusion positive, this is available, I think, many centers, including at Tata Memorial Hospital, but I guess these drugs are not available in India. So any experience with any of these molecules?
There are no robust data for immunotherapies in the LMS.
Right.
Per se.
In fact, I think it's negative only. Whatever studies have shown,
yes,
there's no response. So I agree with you. And there are some maybe level 2B evidence that a tumor with high mutational burden may considered with the pembrolizumab. But
I have a question in chat box, ma'am.
Amita, NTRK is generally a different sarcoma. It's not in leiomyosarcoma. In general, it's a different sarcoma, and usually it is seen in the cervix.
Of course, I mean, we don't do BRCA testing, but there is some, maybe there is a role of PARP inhibitors in some of those which are BRCA2 mutant.
I have a question in the chat box, ma'am.
What did you say? What first
I
choice?
can't see because my screen is, I can't see the chat box.
So what's
the first choice?
choice?
Gemsite, docetaxel, or adramycin? His question is, madam.
At our center, Adria, single agent Adria is the first choice. I don't know. I mean, what others?
So, but I think that clearly some of the randomized control trials have shown that single agent is as good as doublet. So if you want to give some doublet, we have to call the patient because day 1, day 8, we have to give the Gemsite, and Gemsite have been also fixed dose regimen. There are so many again dose after dose taxel, we have the growth factor to prevent the neutropenia. So there are so many, something like a quality of life is not that good as a single agent adramycin, unless if the patient is having some contraindication to give the anthracycline based therapy, like in a cardiac comorbidities or something. Otherwise, I think
even a gem-dosing combination it doesn't cause that much neutropenia, and mostly used in a relapse setting. We don't use it upfront gem-dosing, but yes, gem-dosing doesn't cause that much neutropenia because already patient was exposed many of the times to initial hypohidrosis. So we did reduce dose, and I don't think it's that neutropenic combination. Tolerance wise, it's tolerable.
The intent of treatment here is cure, because a metastatic setting always will compromise the dose. But in adjuvant setting, we never compromise the dosage, and there is a problem here. So that's all.
Right. I think that's very important not to compromise on doses. And I think majority patients would require more than one line of chemotherapy. So it may be the question of how you schedule various chemotherapy regimens. And of course, tumors which are hormone receptor positive, we have AIs or progestogen or other anti-estrogenic therapy. But one point here is that tamoxifen is contraindicated because it has possible agonistic activity on uterine sarcoma. So that should not be used, but we do have other options. And we have actually many patients of low-grade ESS and some LMS, which are receptor positive, have good response to anti-estrogenic therapy. So we should not forget this, and that's why it's essential to do ERPR especially in low-grade ESS, because it has therapeutic implications later. So coming back to our patient quickly, I don't know how much time we have. We gave her, considering it was stage 2B disease, 6 cycles of doxorubicin. She was free of disease for 20 months. Quickly, how do you follow these patients? What imaging do you do on follow-up?
Yeah, nowadays I think that's because the patient already got cured, we can do chest, CT, and abdomen and pelvis. CT is sufficient, madam. There's no role of CT.
Yeah. So, but 20 months later, she developed port site metastasis, and there was some pelvic deposit, but there was no distant metastasis. So we did PET CT at this point. So my question is to Dr. Rupinder, do you think any role of going in again here?
Yeah, depends what the PET CT says. If there is localized disease, we can definitely address it. But if it is a disseminated disease, we would not do any cytoreductive surgery. Simple.
So in selective patient, secondary cytoreductive surgery does have a role. What about HIPEC? You know, I think no discussion can be complete without touching upon this.
No, there is definitely no role of HIPEC in leiomyosarcoma. Absolutely none.
So there's no evidence, although I do see patients who undergo HIPEC, but there is no evidence on a roll-up. So we did surgery for her. There was a port site met. This was laparoscopy port, and there were few.
There's no rationale. I said there's no evidence and there's no rationale at all.
In this patient, in this patient, we might use radiotherapy, as there is only pelvic disease and port site, rather going for surgery, I guess.
No, how?
Why not surgery? Why not surgery?
Surgery, if it is surgery, because it is a recurrent setting. If a patient is fit for surgery, definitely surgery should be the first choice. If not, then we may consider giving radiotherapy, local radiotherapy.
Yeah, young patient, limited disease. That's why we consider her for surgery, and she underwent optimal surgery. There was no gross residual disease. And here comes the question of what adjuvant, what therapy will we give now? Chemotherapy. So we treated her with the doxorubicin upfront.
So we are left with only docetaxel.
JM dose.
we can't give again docetaxel once again.
Right. So we did actually use docetaxel and gemcitabine 6 cycles. Again, she was fine for another 9 months, but again experienced a recurrent disease, and this time it was distant mets. So what option she has now?
I think she should be put on oral pazopanib. That's
oral pazopanib. Yeah. So that's what. Right. So that's what we did actually, pazopanib, but unfortunately she experienced toxicity with pazopanib. I mean, I used to think that this is quite a, oral drug and quite a safe one, but I guess it has significant toxicity. She could not continue. And even while on pazopanib, her disease progressed and eventually she succumbed to her disease. So that was the thing. Any other option you think she had?
Anybody take her for lenvatinib with pembro combination in MSI negative patient?
But the problem here is,
I was wondering why these tongue twister targeted therapies have not come so far. Yeah, please.
Yeah, only one thing, but immunotherapy will not work in this uterine sarcoma. Clearly best said, because this MSI, one of the target for immunotherapy is MSI, microsatellite instability. And the second one is something, this tumor mutation burden. So these are two things, apart from your PDL1, these two are some, for example, colon cancer. So there the MSI is high, then because there are some deficient repair, something. So in these targets are very, very low in this uterine sarcoma. So immunotherapy is out. So next, any target therapy, I think sir I mentioned clearly, sir. So if we identify any target, then we can think of this future target therapy. At this moment, target therapy is nothing but just like pazopanib and everything, trabectedin, all these things are something drugs which we are using out of frustration. But otherwise, there is no quality of, unless the survival is not more than 2 to 3 months, whatever drug we use in this setup. So good counseling.
With eribulin or dacarbazine, what about eribulin? Is it?
It can be done, madam. It can be given very short infusion, very good drug, but problem is toxicity is a big problem. Once submitted, the cost toxicity also, financial toxicity also very high. So it's we have to think in that terms also. But the outcome is not that great, madam. At any other panel member, they have some experience, but even the eribulin in breast cancer also, we don't see much benefit in that.
This is our small experience. Small series. So median age of our patients is around 50. LMS is the most common, and as we discussed, both OFS and DFS are OS under 50% and DFS around 25%. So I think this is the story for most centers. Unfortunately, despite so many advances, uterine sarcomas still have poor prognosis. And the other unfortunate part, what we see nowadays is a lot of women, these women undergo uterine, either fibroid morcellation or morcellation of the uterus by laparoscopic surgeon, and that adversely affect the prognosis. So I think with this, we will end unless we have some question or comments from any panelist.
Thank you very much, madam, for bringing this and wonderful your personal experience. That's the most important. Yes. Thank you once again for all the time, giving us the opportunity. Yes. Yes.
Yeah. If no more comments,
Thank you so much.
Thank you so much, and thank you, organizers, on behalf of all of us. Thank you for giving us this opportunity.
Thank you.
Thank you, ma'am. Thank you so much for nice presentation.
Yeah. So thanks to everyone and to be with us till last, and we request all of you to join for tomorrow also, whatever time it's possible for all of you. And we thank for your active participation. And with this, we conclude today's day one session of the third edition of the BCOS conference webinar, that is the Best Clinical Oncology Symposium. And we could cover a few of the new breakthrough which has come through this ASCO 2022. And tomorrow we will be covering some more aspects. With that, I thanks once again, and goodbye and good night to all of you.
Thank you,
Bye.
sir.
Good night.
Thank you.
Thank you.
Good night.
Thanks a lot.